Anyway, I am going to talk about the artificial intelligence in ophthalmology. What is artificial intelligence? It is the capability of the machine or tool to perform the task that need human brain power. That means the human brain power is essential. Page up and down. There are various AI tools that will help in diagnosing and treating the disease. Particularly, I will say there are about 2,000 to 3,000 AI tools present, but in ophthalmology, we are having about 200 to 300 AI tools, which is helping in the diagnosis and treatment of the ocular diseases. Few example I can quote here, that is Remedio, Rate Marker, INAC, IDX-DR, Ocular Disease System, 4net. AI integrated in our routine life also. One is the robotic surgery, you can see in smartphone also, you can see in the digital wearable devices or in the biometry. Nowadays NMC is asking for biometry everywhere. So it is here the artificial intelligence which is coming in picture. So in ophthalmology, where we can use the AI tools, first and foremost is the glaucoma. In the glaucoma, it is important to have in the visual field interpretation, OCT, IOP, and all the other glaucoma fields. Especially here, I will tell you in the visual field interpretation, early diagnosis, accurate diagnosis is very important, because most of the patient which is coming to are in the late stage. So AI glaucoma tools that is helping in the early diagnosis and early treatment, so we can know the progress also. Second is the cataract. Cataract in the adult and pediatric type of cataract are different type of cataract. So early diagnosis and their progress you can know by AI tool. And one is PCO is now a common problem we are facing. So PCO we can predict in advance also. There is possibility the patient will get the PCO by AI tools. There are various tools, so many names are given. So here I cannot enumerate the names of all the AI tools. Okay, the IOL calculation is an important thing. If you put a wrong IOL, then the result will be poor. So accurate IOL calculation power by AI tools can be done. So what you have to do, so AI there are new tools which is available for accurate measuring of the AC length, lens thickness, and the cataract validity. As far as the anterior segment diseases are concerned, that is first is the cornea. In the cornea, the genes play an important role, particularly in the keratoconus. Early diagnosis of the keratoconus is possible with the AI tools. So that can give you some idea what will be what is going to happen in future. As far as the pterygium, endothelial disease and corneal graft is concerned, AI tools are here again very, very important. If there is some endothelial disease, whether it is going to progress or what is going to happen, that you can by giving the pictures of the slit lamp, by seeing the pentacam, by seeing through the other things, you can find out what is the possibility of the keratoconus in possibility of endothelial disease progression, especially the Fuchs endothelial dystrophy. Corneal graft is concerned, in the corneal graft, pre-operative assessment is a very important thing, because the result will depend on that one. So pre-operative complete assessment you can do with the AI algorithm. In the retina, early diagnosis of the macular edema is an important thing, which is reversible, that you can find out with the AI tools. In the diabetic retinopathy, you can find out how it is progressing, what you can do, and if you have given the treatment, how the treatment is helping you. That is all possible with the AI tools. In the ARMD diagnosis also and its progress also, you can have an idea how it is going to progress. So early treatment can help you. Pediatric, especially in the pediatric ophthalmology, nowadays to diagnose ROP is a very important thing. So you can diagnose the ROP, because in the children or in the infant, to see the patient and to take out the outcome is a very difficult task. So in if you are able to take out the picture of the fundus, you can take the help of the AI tools. And so in the ROP, you can see where the things are going and how your treatment is going to affect the things. In refractive error, nowadays everybody asks for the best result. Best result. So do the pre-operative refractive, all the assessment and find out what is the possibility. Because after doing the refractive surgery, some patient can get ectasia. So you can assess by an AC thickness, NTS chamber and everything whether patient is ideal for refractive surgery or not. In the ophthalmic surgery, all the pre-operative and post-operative refractive surgery, you can find out the AI tools, how it is going to give the result. As far as the teleophthalmology is concerned, you see many of the persons or patients or even the doctors are sitting in the periphery. They can take the help of the AI. You can also know the progress of the disease. In case something is required to change the treatment part also, you can tell to them. So persons who are sitting in the periphery, there this teleophthalmology by AI tools can help you. In ophthalmology, AI is really revolutionizing the things. The early detection is there.
Sum up, sir. Your time is over, sir. Please.
Okay, I'll say something about the conclusion. In the conclusion, there is an immense capability of future AI application in all subfields of ophthalmology. Early diagnosis, accurate identification, teleophthalmology results in the providing efficient health care. AI is still debatable because somebody says the AI is going to be better than the human ophthalmologist, which is a debatable point. Apart from the ophthalmology, AI is used in social governance and healthcare development. Thank you very much.
Thank you, Dr. Arun. Please collect your certificate. Who is next?
This is two-side trabeculectomy with phacoemulsification. Introduction. The term phacotrabeculectomy was first introduced in the literature in 1991. The combined procedure of phaco and posterior chamber intraocular implantation with trabe has been advocated for treating coexisting glaucoma and cataract. Less surgically induced trauma, less surgical induced astigmatism and better postoperative IOP control have augmented this trend. Phacotrabe is performed through the same incision. This is called one site, or through separate incisions called two site. This is the picture for separate incision for phaco and trabe. This is two site approach. And next is same incision for phaco and trabeculectomy. This is one site approach. Aim of this study was to compare IOP control in one site versus two site phacotrabe and to compare post-operative astigmatism changes. This prospective study will be conducted after taking informed consent from patients. Design was 40 patients and 40 eyes. Group A was for one site 20 patients and Group B were two site for 20 patients. Inclusion criteria: age group above 20 years, poorly controlled IOP with two or more anti-glaucoma drugs. Most patients were on brimonidine, timolol and dorzolamide, and presence of a visually significant cataract. Exclusion criteria was eyes with corneal opacities, posterior segment disorder, cataract that could not be safely removed by phaco, and age group less than 20 years. This was the results analysis of IOP control. The pre-op IOP was in one site was 26 plus minus 6.5 mm of Hg, for two site 28 plus minus 7.1 mm of Hg. Post-operative, there were 3 follow-ups: day 1, 7 and 1 month. The results were at time of 1 month is mean IOP one site was 16 plus minus 5.1 mm of Hg, and for two site is 15 plus minus 4.9. The p-value was same group was 0.001 and 0.001. Number of anti-glaucoma drugs in one site after surgery and two site after surgery was 1.6 plus minus 0.8. For two site is 1.9 plus minus 0.8. 18 eyes, 90% in the two site group and 85% in the one site group had controlled IOP without medication, while 19 eyes in two site and 18 eyes in one site respectively achieved controlled IOP with medication. One eye in one site group was in hypotony. IOP was less than 4 mm, which leads to choroidal detachment, which was managed medically. Analysis of surgical induced astigmatism. In one site, the range was 0.3 to 2.1 diopter. Mean was 0.89. And for two site, the pre-op range was 0 to 2.1 diopter and mean was 0.97. Post-op, in one site range was 0.2 to 1.8. Mean was 0.80. and for two side range was 0.2 to 2.0 and mean was 0.90. Comparing pre-operative and post-operative estimating vector powers using Wilson sign rank test, outcome was established significant in single site group. P was 0.055 and not significant in twin site group. Managing coexisting cataract and glaucoma remains complex and controversial. In conclusion, both the two commonly used technique of combined cataract and glaucoma surgery proved to be efficacious without significant differences in surgically induced astigmatism. There is no difference in IOP reduction between single site and twin site techniques. Thank you.
Thank you, Dr. Arvind. Please collect the certificate. आप invite करते हैं next.
कौन है सर? Next speaker, Dr. Akshika Damiza, Dr. Khyati Yadav. Anyone?
Topic for my paper presentation is to evaluate the ocular manifestations in psoriasis patient. Introduction. Psoriasis affects 1 to 3% of the adult population with various extracutaneous manifestations. Around 10% of psoriasis patients have ocular manifestations. Ophthalmic manifestations are numerous and generally tend to occur much later after the skin involvement. Ocular manifestations are subtle and are often overlooked. If ocular examination could be carried out at regular intervals, patient with psoriasis would be benefited. Ocular manifestations affect the lid, conjunctiva or cornea, resulting in the development of ocular manifestation, the commonest being dry eyes and blepharitis. Others include pinguicula, punctate keratitis, cataract, uveitis, glaucoma and retinal microvascular abnormalities. Various morphological types of psoriasis are chronic plaque type, guttate, pustular, erythrodermic. The classical lesions were well demarcated plaques on an erythematous base with silvery scales on the surface. The aim of the study was to evaluate the ocular manifestations in psoriasis patient. The objectives were to assess the frequency of ocular manifestation in psoriasis patient, to study the various clinical manifestations of psoriasis in the eye, to investigate possible relationship between the frequency of ocular involvement and patient age, sex, duration of illness since diagnosis, type of psoriasis and severity of the disease. The present cross-sectional study was conducted in the Department of Ophthalmology, SP Medical College, Bikaner, among 50 psoriasis patients. Clinical type of psoriasis, duration of disease, site of involvement and severity were noted. Slit lamp examination, fluorescence staining of the ocular surface and fundoscopy was done. Dry eye evaluation was performed by measuring the values of shimmer 1 and tear film breakup time. Inclusion criteria: patients more than 18 years of age with diagnosis of psoriasis. Exclusion criteria: patient with diabetes mellitus and renal disease, patients using contact lenses and patients aged less than 18 years of age. Prevalence rate of ocular involvement in psoriasis was found to be 58%. Most common ocular finding was conjunctival hyperemia 46%, followed by dry eye 36% and blepharitis 26%. Scalp psoriasis was found to be significantly associated with blepharitis. This is the table showing the correlation of ocular involvement and age, gender, disease duration and psoriasis area and severity index score among the study group. It was found that between the age 18 to 15 years, 35 patients had psoriasis, out of which 17 had ocular involvement. Between age 51 to 80 years, 15 had psoriasis and out of them 12 had ocular involvement. No significant correlation was found between the frequency of ocular manifestation and factors such as age, gender, duration and severity of psoriasis. Ocular involvement in psoriasis is not well described in the literature. Prior publications from Europe and Far East Asia have reported the incidence rates for ocular findings in psoriasis to be around 10%. However, higher rates varying from 50 to 80% have been reported in recent studies. Due to climatic and racial differences between the Indian population and the population from Europe and Far East Asia, the manifestation of ocular psoriasis would differ. Very few studies have been done showing ocular manifestation of psoriasis in India. Prevalence rate of ocular involvement in psoriasis was found to be 58%. Most common ocular finding was conjunctival hyperemia 46%, followed by dry eye 36% and blepharitis 26%. Similar to our conjunctival infection was detected among 40% of the patients with psoriasis in a study by Omar and Hilali. Scalp psoriasis was found to be significantly associated with blepharitis. Statistically significant relationship between scalp psoriasis and blepharitis, which is consistent with the study done by Abbagani et al. We did not observe any statistically significant relationship between the rate of prevalence of ocular findings and the factors such as age, gender, duration of psoriasis, and PASI scores. This is consistent with the results reported in earlier publications. Sample size of different clinical variants of psoriasis except psoriasis vulgaris was very small. Hence, we could not calculate the statistical significance of ocular involvement in these areas. Ocular manifestations in psoriasis are common and they affect mostly the anterior segment of the eye. Routine ophthalmological evaluation is important in these patients for early diagnosis, which in turn can prevent sight-threatening complications. Thank you.
Thank you, Dr. Khyati. Please collect your certificate. Anyone who is ready can come. Next speaker is Dr. Smriti Singh.
Good morning, sir and ma'am. Topic of my paper is correlation between corneal astigmatism and morphology of pterygium before and after surgery. Pterygium is a wing-shaped fibrovascular connective tissue that originates from the bulbar conjunctiva and extends towards the center of the cornea. Pterygium can lead to considerable changes in corneal refractive status before it reaches the optical zone. These studies revealed that larger sizes of the pterygium have stronger correlation with corneal astigmatism. Anterior segment optical coherence tomography provided detailed information about the ocular surface and used to understand the anatomical relationship between pterygium and the cornea. We use ASOCT to evaluate how pterygium size and morphology affect the corneal astigmatism. We take the detailed demographic data of the patient along with ocular examination, including subjective refraction, best corrected visual acuity measurement with Snellen's chart, anterior and posterior segment examination with slit lamp microscopy, keratometric measurement by corneal topography, pterygium morphology analyzed with ASOCT were performed in all subjects. So this is one technique, how we have taken the vertical and the horizontal diameter. The size of the pterygium, horizontal length and the vertical width was measured manually using millimetric scale. Pterygium area and percentage extension of the pterygium onto the cornea was calculated. Horizontal length, the horizontal length was defined as the line between the apex of the pterygium and nasal limbus, and the vertical width was defined as the dotted line as shown in the figure. Morphologically, two tomographic patterns were identified on ASOCT, continuous and nodular. Correlation between anterior corneal astigmatism and pterygium size, percentage extension of the pterygium, which is total horizontal length divided by diameter of the horizontal cornea, and morphological pattern of the pterygium was analyzed. So the figure 1 is showing this one, anterior segment photograph of pterygium with nodular pattern, and this figure is showing the anterior segment optical coherence tomography horizontal scans of the nodular pattern with delineated masses of the pterygium tissue bulging the ocular surface contour and with creeping extension of the apex below the corneal epithelium. This is the anterior segment photograph of the pterygium with continuous morphology. This is the ASOCT scan of horizontal scan of the continuous morphological pattern with more extension and creeping of the end of the pterygium apex below the corneal epithelium. So we get the results, the frequency distribution of the morphology of pterygium. We have taken the 47 patients, from which 28 were nodular and 19 were continuous. Distribution of the gender of the patients, 32 were male and 15 were females. Now we have compared the pre-op and post-op K1, K2 values and the test and P values. Now the correlation coefficient between pterygium parameters, K1 variables. So this is the horizontal width, the vertical length and percentage extension values in the K1 variables. And the correlation coefficient between pterygium parameters and K2 variables, the horizontal width, vertical length and percentage extensions value according to the K2 value we have compared. So my conclusion is, although not statistically significant, the result of this study demonstrated that while increased pterygium sizes are related to higher anterior corneal astigmatism, the morphology of pterygium does not have a significant effect. Thank you.
Good morning, everyone. Myself, Dr. Babulal Serao, Junior Resident, Dr. Hassan Medical College, Jodhpur. I am presenting assessing visual outcome intraocular pressure in lens-induced glaucoma post-surgery under guidance of Dr. Arvind Chauhan, Head of Department, Dr. Punish Singh, Associate Professor and Unit Head. Introduction. Glaucoma is the leading cause of blindness in developing countries. Is preventable with increased awareness. M. Analyzing visual outcome and intraocular pressure control post-surgery in lens-induced glaucoma cases. Primary objective: determine post-surgery visual improvement and intraocular pressure management. Secondary objectives: investigating surgical complication and reason for the reduced visual acuity in various surgical approach. Material and methods. Subject selection: 100% with lens-induced glaucoma attending glaucoma services in Dr. Hassan Medical College, Jodhpur. Inclusion criteria: patient with phacolytic glaucoma, phacomorphic glaucoma, phacoanaphylaxis, lens particle induced glaucoma, any subluxated and dislocated lens with rise intraocular pressure. Exclusion criteria: patient under the age of 18, patient with primary open angle glaucoma, primary angle closure glaucoma, patient with secondary glaucoma, patient with uncontrolled diabetes, hypertension and ischemic heart disease. Examination methods: all were subjected to anterior segment examination by slit lamp biomicroscopy. Best control visual acuity by Snellen chart. Intraocular pressure management either by Goldman ablation tonometry. Fundus examination: in case with no fundus, B scan will be done. Gonioscopic examination with Goldsman single mirror lens. In case of subluxation and UBM will be done to know the degree of the zonular dye sense. Routine investigation like blood examination, urine examination, blood pressure management will be done. Keratometry, axial length and IOL power will be calculated in patient undergoing surgery. Follow patient. Follow patient is post-operative patient follow with day 1, day 3, day 7 and 2nd and 4 and 6 week. In each visit, visual acuity measurement, anterior segment examination by slit lamp, intraocular pressure with non-contact tonometer and fundus examination will be done. End of the month, gonioscopy is repeated and field examination is done with automated perimetry. Results: age distribution shown as per the chart. Sex distribution: 41% male and 59% female. Vision at the time of presentation. Table showing the vision in the patient at the time of presentation. Intraocular pressure at the time of presentation. IOP range. Percentage of various lens-induced glaucoma. Phacolytic glaucoma 60%, phacomorphic glaucoma 29%, lens particle-induced glaucoma 10%, subluxated lens-induced glaucoma 1%. Lens status in affected eye. Hypermature cataract 50%, mature cataract 49%, immature cataract 1%. Lens status in other eye. Other eye present with PCIOL 72%, mature cataract 28%. Visual acuity in other eyes. Table showing visual acuity in other eye. Types of surgery done. Various surgeries, combined surgeries, SICS with trabeculotomy, ECE, SICS with peripheral iridectomy, SICS with lens removal. IOL implantation in 100%, 95% patient operated with PCIOL and 5% patient left aphakic with due to complications. Surgical complications in 100 eyes operated, 68% case had stated keratopathy postoperatively, and 100% cases with iritis, 43% patient present with zonular discence, 12% patient had posterior PCR rent, and 5% with vitreous loss. Post-operative visual outcomes. Table showing visual outcome in post-operatively periods. Post-operative IOP controls. Table showing IOP reduction in the post-operative periods. Post-operative day 1, day 3, day 7, post-op second week, post-op 4th week, and post-op 6th week. Visual field examinations. 100 cases at the end of the 6th post-operative weeks, 90% showing normal visual field, 5% show abnormal visual field due to complications. Discussions. Patient demographic. 50% case were in the found 56 to 60 age groups. Sex 59% were male, but sex did not significantly affect the disease and treatment. Presentation. 51% with the PL vision, and 48% with head movement vision, and 1% had 1/60 visions. IOP at the presentation, 47 had IOP in the range of 28 to 32 mm of Hg. Lens-induced glaucoma types, 60% cases are phacolytic, 29% are phacomorphic, and 10% lens-induced particle glaucoma, 1% subluxated lens. Lens status affected eye, 50% hypermature cataract, 49% mature cataract, and 1% mature cataract with subluxation. Lens status in other eye, 72% had the PCIOL, often leading to the late presentation. Visual acuity, other eye, 57 had the vision range 6/36 to 6/18 vision, and 30% patient had the vision of 6/12 to 6/9. Surgical approach, 50% with combined surgery, 60% ECC, and 54%.
Please sum up. Your time is over. Conclude कर लो.
Conclusion. Vision ignored no more. Lens-induced glaucoma often stem from long-standing cataract or trauma. Patient had with good vision in one eye and often overlook vision issue in other eyes. Education and timely cataract surgery essential to preserve vision, and especially in the rural areas. ICAM can be bridge the accessibility gap and reaching those in the remote village. Surgery unveils in brighter world. Surgery is the cornerstone in lens-induced glaucoma treatment. It ensures intraocular pressure control and facilitates vision improvement with the surgical intervention. 95% cases experience an enhanced quality of the life. Through proactive measures and surgery, we bring vision into focus and transform lives. Thank you.
Thank you, Dr. Babulal. Please collect your certificate. Anyone who is ready, please come forward. Yeah, please come. Next presenter is Dr. Ashita.
Hello, good morning to everyone. I am presenting a case to evaluate the efficacy of prophylactic administration of topical NSAID on macular edema following cataract surgery in diabetic patient, and to compare between type of NSAIDs, keratolactromethapine 0.4% and napafinec 0.1%. Introduction. Cataract in diabetic patient with its high prevalence and earlier age of development is considered as a major problem against adequate fundus examination and laser photocoagulation therapy in addition to decreasing visual acuity. Macular thickening is a well-known post-operative complication after cataract surgery, even with uncomplicated surgery. The pathophysiology of diabetic retinopathy is mainly microangiopathy, in which small blood vessels are affected by occlusion and leakage. The blood-retinal barrier in diabetic eyes is impaired to a variable degree and is responsible for developing post-operative CME depending on the many factors including duration, severity of disease, presence of retinopathy, and previous treatment with photocoagulation or steroid injection. Fluorescence angiography is considered a gold standard for diagnosing macular edema. Prostaglandins play a role in pathogenesis of diabetic retinopathy and macular edema is reported. NSAID are potent anti-inflammatory medication which decrease pro-inflammatory prostaglandins by their inhibitory effect on cyclooxygenase. This study was conducted to evaluate the efficacy of prophylactic administration of topical NSAIDs on macular edema following cataract surgery in diabetic patients and to compare between types of NSAIDs, keratolactromethamine 0.4% and napafinec 0.1% in preventing macular edema in diabetic patient undergoing phaco-cataract surgery. Method. Group 1 control received artificial tears substitute as a placebo group. Group 2 napafinec received topical napafinec 0.1% and group 3 ketorolac received topical ketorolactromethamine 0.4%. Patients were examined post-operatively after completing 1 week, 1 month, 2 months and 3-month intervals for evaluation steroid macular edema development. The main study outcome were achieving the best corrected visual acuity and change in the central macular thickness measured with OCT. Result. Best corrected visual acuity show a statistically significant difference at the 3rd month post-operative follow-up between the control group and the NSAIDs group. Significant value 0.04%. There was an increase in the CMT in all cases starting from post-operative 1st week until 3rd month. Central macular thickness showed a statistically significant difference between control group and NSAID group from post-operative 1st month until 3rd month. There was no statistically significant difference between napafinec and ketorolac. Discussion. This prospective RCT demonstrated the value of addition of 2-day pre-surgically and 2-month post-operatively topical NSAIDs as a prophylactic regimen to the topical corticosteroid after uncomplicated phaco in diabetic patient. The effect appear obviously on OCT, CMT and BCVA. In addition to that, it also compared the efficacy of napafinec and ketorolac eye drop on macular thickness. The reason behind the selection of diabetic patient undergoing cataract surgery to be included in this study is the fact that change in the blood retinal barrier in diabetic patient carry a high risk of development of post-operative macular edema in those patients even if they had no pre-operative diabetic retinopathy or DME. Patient with DR with excluded from the current study to avoid acceleration of diabetic retinopathy. Following the same concept, we decided to use the CMT to assess the development of post-operative macular edema. Pseudophakic CME is usually presented with a central macular edema and cystoid fluid accumulating in the central macula. In contrast, DME typically has a higher retinal volume and diffuse or focal retinal thickening. Perhaps the most important finding in this study was that the addition of preoperative NSAIDs to the standard therapeutic corticosteroid regimen used after uncomplicated cataract surgery decreased the occurrence of post-operative CME. Incidence of CME or OCT CMT was evident with significant difference between control group and NSAIDs group. No case of clinical CME increased central macular thickness more than 40 micrometer from preoperative baseline were detected in the group received NSAIDs. In contrast, clinical CME was detected in 10% of patients in control group. Conclusion. Prophylactic preoperative and postoperative NSAID may have role in reducing the frequency and severity of CME in diabetic eye following cataract surgery. Thank you.
Next speaker, please be ready.
Good morning, everyone. I'll be presenting my paper on impact of blunt trauma on ocular structures. Introduction. Ocular trauma is one of the most under-recognized causes of vision loss. The age distribution for serious ocular trauma is bimodal, with the maximum incidence in young adults and a second peak in the elderly. Blunt eye trauma can manifest as open globe or closed globe injuries. The closed globe injuries are broadly classified as contusion and lamellar lacerations, while open can be divided into laceration and globe rupture. The mechanism of blunt trauma can be due to Coop counter-Coop mechanism or anterior-posterior compression or horizontal expansion of the tissue. Although the impact is primarily absorbed by the lens iris diaphragm and the vitreous base, damage can also occur at a distant site such as the posterior pole. Proper assessment of the ocular damage and starting treatment immediately after the injury has an important effect on the final outcome. Materials and methods. This cross-sectional study was conducted at Sardar Patel Medical College, Bikaner from April 2020 to March 2021. Patients with the definite history of recent blunt trauma to one or both eyes presenting to the outpatient clinic or referred from the trauma casualty department of SPMC Bikaner of all age groups who were willing to participate were included in the study. The patients with the history of penetrating ocular trauma, previous ocular trauma, or vital fractures and not willing to give consent were excluded. A detailed history regarding the age, sex, occupation, causative agent, duration of the injury, direction of the force, signs and symptoms occurring following the injury were taken from each patient. Complete ophthalmic examination was done, including vision, IOP, direct ophthalmoscopy, and slit lamp examination. Observations and results. It was seen that the maximum cases were in the age group of 16 to 30 and least were in the among the age group of more than 60 years. This is a table showing distribution of cases according to the source of injury. It was seen that the maximum cases were of RT and assault. The distribution of cases according to the time interval following blunt trauma. Maximum cases reported to the hospital within 24 hours and least reported after 1 month, mainly with complications. Distribution of cases according to the ocular structure involved. It was seen that the maximum lesions were conjunctival lesions followed by periorbital region and least were in the anterior chamber, that is hyphema. Then the distribution of cases according to the segment of eye involved, it was seen that the purely anterior segment involvement was maximum and least was of purely posterior segment. Discussion. In our study consisting of 100 cases, incidence of ocular surgeries was found to be highest in the younger age group of 16 to 30 years, that is 55%, and the male to female ratio being 3:1. In our study, it was observed that the 55 patients were involved in RT and assault, followed by occupational injuries. It was observed that the 64% patients consulted within 24 hours, followed by 24% in 1 to 5 days, whereas minimum 2% patient consulted after 1 month with complications. The periorbital lesions were seen in 57% cases, conjunctival lesions being the maximum, followed by corneal involvement, iris, and posterior segment with least involvement of the anterior chamber. It was observed that 77% cases have purely anterior segment injuries, whereas 6% has purely posterior segment injuries. In our study, the lid injury presented as maximum cases with ecchymosis, followed by edema in 49%. Out of conjunctival lesion, subconjunctival hemorrhage was found to be the commonest presentation in 53%. It was observed that 35% cases has corneal involvement, out of which 14% had corneal edema, and amongst them, 3% were associated with hyphema. IOP in these cases were high initially, which came to normal within a week. It was found that 17% had lens involvement, out of which total opacity was seen in 14%, while subluxation in 3% and dislocation in 1%. The study revealed that the 21% patient had posterior segment damage, in which maximum cases were of vitreous hemorrhage, followed by macular edema, and least were of choroidal hemorrhage. Conclusion. Ocular trauma has to be considered a public health priority in developing countries like India, as most of the patients affected belong to the economically productive age group. As blunt trauma is the major cause of preventable visual impairment, prevention is better than cure aptly applies here, and the onus is on all the clinicians to educate patients on eye safety. Mass health education and awareness about the ocular trauma and morbidity caused by the delayed presentation and need to adopt safety equipment should be focused upon. Thank you.
Thank you, Dr. Devanshi. Please collect your certificate. Who wants to come next? Next presenter is Dr. Devansh.
Good morning, everyone. I'm presenting a paper on simple limbal epithelial transplant. Introduction. Simple limbal epithelial transplant is a single stage procedure for limbal cell deficiency. It helps overcome the need for a special laboratory setup for cultivation of stem cells as required for cultivated autologous limbal epithelial transplant. It allows autografting of 2 mm of donor limbal tissue from the healthy to the diseased eye. SLET is cost-effective procedure which forbids need for lifelong immunosuppression as necessary for keratolimbal allografting. Principle: SLET procedure involves transplanting small number of limbal stem cells from the central contralateral eye to the recipient's eye having limbal cell deficiency. It involves placement of limbal stem cells on human amniotic membrane graft derived from the epithelial side of placenta. The transplanted viable limbal epithelial cells with the help of FAM allows reepithelialization of the corneal epithelium, helping resume the clarity and function. The presence of new healthy limbal stem cells can prevent growth of conjunctival cells over the corneal surface. Materials: patients with unilateral limbal stem cell deficiency due to chemical injury, patients with unilateral thermal injury, iatrogenic topical antimetabolite use like mitomycin C and 5-fluorouracil, iatrogenic large ocular surface surgery and prolonged VKC, prolonged contact lens usage, and immunological conditions like Stevens-Johnson syndrome and pemphigoid. 50 patients underwent SLET for limbal cell deficiency. Out of the 50 patients, 25 patients underwent SLET for post-chemical and thermal burn, 13 underwent SLET due to Stevens-Johnson syndrome, 7 patients post-VKC, and 3 patients post-antimetabolite use, and 2 patients post-contact lens usage. Method: 2 by 2 millimeter strip donor limbal tissue is obtained from the healthy eye. It is divided into 8 to 10 small pieces using Varna scissors. The surgical preparation of the recipient ocular surface is done. Limbal transplants distributed evenly over the amniotic membrane placed on cornea, and finally implantation of the VCL over the limbal tissue. This is a diagram showing the procedure. This is the first patient who is a 36-year-old patient who suffered from a Lyme injury. This is a pre-operative photograph. Here we can see pannus formation and conjunctivization of the corneal surface. This is the post-op after 1 month, and here we can see vascularization, which is decreasing. This is the 5-month post-op, and we can see decreased vascularization and clearing of the cornea and increase in clearance of the surface. This is the post-op 1-year photograph, where we can see that the corneal surface has healed and there is no vascularization is seen in this case. This is the second patient who is a 20-year-old male and who also suffered from Lyme injury. This is a 5-day post-op. Here we can see the limbal tissue which we have implanted along with the vascularization. This is the 10th day post-op where we can see the decrease in vascularization and increasing in the clearance of the graft. This is post-op day 20. This is the post-op day 30. This is the congenital patient who suffered congenital limbal stem cell deficiency, 4-year-old patient, pre-operative image, where we can see extensive pannus and there is vascularization along with the haziness of the corneal surface. This is post-operative day 5 image, and this is post-operative on 8 month. But in this patient, we couldn't resolve the vascularization of the corneal surface. So the outcome was out of the 50 patients total overall, 43 patients had successful outcome, 5 patients had partially successful outcome, and 2 patients suffered from failure of the surgery. In successful outcome, we saw completely epithelialized avascular cornea. In partially successful outcome, we saw focal epithelial defects and focal recurrence of symblepharon, which is not in visual axis. And in failure, there was unstable ocular surface or persistent epithelial defect, or vascularized cornea or symblepharon in the visual axis. The visual outcome was all patients before surgery had a vision of PL positive or hand movement close to face. Out of the total 50 patients, 42 patients developed gross visual improvement of more than 2 lines on Snellen's chart. 7 patients had minor improvement from hand movement to finger count close to face, and 1 patient has no visual improvement. But out of the 42 patients, 38 patients had 6/36 vision, 6 patients showed 660 final outcome of vision, 4 patients showed finger count close to face, and 2 patients has 6/18 of vision. The conclusion is, after surgery, completely epithelialized and stable corneal surface with the direction of the vascularization and clearing of the cornea was seen in majority of the patients at 10 weeks follow-up. The visual acuity improved in majority of the cases. No complications were seen in any eye post-surgery. Thus, this study showed limbal epithelial transplant is an easy and effective technique in patients with unilateral and allogenic simple limbal epithelial transplant for bilateral involvement in cases of limbal stem cell deficiency. Thank you.
Thanks, Dr. Divyansh, for nice paper presentation. Next speaker. Kanav. Yeah, next speaker is Dr. Kanav.
Good morning, everyone. I'm presenting my paper on efficacy of collagen cross-linking as a therapeutic modality in keratoconus. Keratoconus is a non-inflammatory progressive corneal disorder that results in the thinning and conical protrusion of the cornea. As the cornea weakens and bulges, it leads to irregular astigmatism, myopia, and decreased visual acuity. Collagen cross-linking is an innovative treatment that has gained prominence in the recent years as a potential therapeutic option to halt the progression of keratoconus and improve the visual outcomes. The principle and the techniques. Collagen cross-linking is based on the principle of strengthening the corneal tissue by increasing collagen bonds through application of riboflavin and ultraviolet A light. This process induces photochemical reactions that leads to the formation of intra and interfibril bond within the corneal stroma, and there are two primary techniques of CXL, that is epithelium off, that is epi off, and epi on CXL. This is the image showing the procedure. Firstly, the epithelial layers of the cornea are removed and the transition of the riboflavin to the cornea is increased in epi off procedure. Then the riboflavin solution is instilled into the eye every 2 to 5 minutes. The UVA beam of 370 nanometer wavelength is applied for 30 minutes, and by this it increases the number of cross-linking between the collagen fibers via CXL. The biochemical robustness of the stroma is increased. We took patients with progressive loss of vision and patients not improving with spectacles or contact lenses. 45 eyes of 40 patients with early progressive keratoconus were analyzed. And in our series, epi on C3R was done on 14 eyes and epi off procedure was done on 31 eyes. In late reality, only 5 patients underwent both eyes C3R procedures and 4 were epi off and 1 was epi on C3R. The procedure is after applying these Ilocan drops, speculum is applied, 8 mm of the central corneal epithelium is removed to allow the penetration. Disposable sterile solution of riboflavin 0.12% was instilled for every minute for 15 minutes, and then riboflavin was administered every 2 minutes for a period of 30 minutes as the eye is exposed to UVA. And the eyes are thoroughly washed and pad and bandage is applied. The results: 45 eyes of 40 patients underwent CXL. Patients with corneal thickness of 400 to 450 microns underwent epi on, and more than 450 microns were taken for epi off C3 procedure. The minimum Pachy value was 405 and the maximum was 552 microns. and the maximum distribution was seen between the range of 450 to 520 microns. These are the Pecci values taken up for Epion. The maximum was in the range of 421 to 440, and in the Epi-off procedures, the maximum range was in the range of 450 to 480 microns. And in our case series, the sex distribution was almost equally poised in both the genders. Interestingly, on analysis of the K reading of our series, the maximum K value was 63.4 and the minimum K was 49.4. And as a revelation, steeper corneas were not necessarily extremely thin and were also subjected to Epi-off C3R procedures. K values in our cases, the maximum K value was in the range of 49 to 55, that is a total of 21 out of the 45, and in the range of 56 to 60, there were total 15 patients, and there were 9 patients that had a K reading of more than 60. On analyzing the post-procedure Epion response in topography, 11 eyes out of 14 showed good therapeutic response, and flattening was seen in 50% and stability in 29%. 3 cases showed steepening in K values, out of which 2 patients were in the age group of 10 to 15, showing the progressive nature of the disease. On topographic response in Epi-off procedure, flattening was seen in 52% cases, stability in 16% of the eyes, and few patients showed progression in spite of the C3R procedure. These included 3 patients with initial K rating of more than 58 and 5 patients with central corneal thickness less than 480 microns. The flattening response after Epion and Epi-off was almost equal. These are the topo responses on Epi-off and Epion. The visual improvement following Epion C3R was 57%, stable vision noticed in 21.4%, diminution of vision in 21.4%, and diminution of vision is noticed in 1 patient with initial K rating of more than 60 and 1 patient with high cylinder values. The visual response in Epi-off C3R showed improvement in 65% cases and stability in 16% cases. Diminution of vision was seen in 19%, and diminution of vision is analyzed to be in patients with initial K rating of more than 60, patients with low BCVA, and patients with high initial cylinder values. And these are the vision responses on Epion. Improvement in 8 cases, stable in 3, and diminution in 3 cases. And vision response in Epi-off, improvement in 20 cases out of 31 cases, stable vision in 5, and diminution in 6 cases. In our case series, there was visual improvement of 1 line in 11 eyes, 2 lines in 12 eyes, and 3 line improvement in 5 eyes. And the maximum of 3 line improvement is seen in 2 eyes following Epion and 3 eyes following Epi-off procedures. Conclusion: collagen cross-linking is a promising treatment for keratoconus, providing an effective means to halt the progression of the disease and improve the visual outcomes. Early intervention is the key to maximizing the benefits of CXL, emphasizing the importance of regular eye examinations for early detection. With ongoing research and improvements in technique, collagen cross-linking continues to be the valuable tool in the management of keratoconus, offering hope to patients affected by the condition. Thank you.
Thank you. Please collect your certificate. Who is next? Divyansh. Next speaker is Dr. Divyansh. Dr. Divyanshu Sharma, please. Next presenter, please be ready. Come forward and
Please.
Good morning, everyone. I am Dr. Divyanshu Sharma here, representing paper on the comparative study of amniotic membrane graft as an alternative to conjunctival autograft and pterygium surgery. As we know, pterygium is recognized 30 years ago, or we can say that it is before the time of Shushruth. Some persons have found pterygium. Pterygium literally means a wing, or it is an encroachment on the conjunctiva on the cornea, more often on the nasal side. It is found in the areas of high ultraviolet rays, radiation zone, dry, hot, windy, dusty, and smoky environment, or we can say that it is more related to occupation. of the person. The indication of this surgery included reduced visual acuity due to encroachment upon the visual axis and the irregular astigmatism, and also due to chronic irritation and recurrent inflammation and cosmosis. The treatment of choice is surgery, or we can say that most of the time it is conservative management. Various techniques exist with resulting defect being left exposed or covered by surrounding conjunctiva, or a limber, autograft, or other tissue. As an adjuvant therapy with antimetabolites also be tried. The use of amniotic membrane graft is also used as an alternative to conjunctival autograft. The aim of the study is to compare the efficacy and safety of amniotic membrane graft as a variable alternative to conjunctival autograft in pterygium surgery. As we can see the diagrams of the both conjunctival autograft and amniotic membrane graft. Materials and method. There are 70 patients taken at the MDM Hospital, Jodhpur, with pterygium in these studies, in which we divide two groups, 35 patients for amniotic membrane graft and 35 for conjunctival autograft. One group underwent pterygium excision and the replacement with conjunctival autograft use, and the graft is stick with fibrin thrombin glue. As we can know, then fibrin thrombin glue is extract from the intrinsic and extrinsic pathway in our body. The other group, pterygium excision and replacement with amniotic membrane graft using fibrin thrombin glue. Amniotic membrane were obtained from the gynec department. We can use most of the time wet amniotic graft and then processed and stored. As we can see in the intraoperative amniotic membrane graft procedure, routine pre-operative evaluation does as per standards. Relevant ocular history, uncorrected and best corrected visual acuity, slit lamp examination of the type and extent of pterygium, pre-operative refraction and fundus examination, and many more criteria has been taken. Okay. As we see the observation, first we have taken equal patients, like 25 patients for the 35 patients for conjunctival autograft group and 35 for amniotic membrane graft group. We can see the age and sex distribution of the patients showing pterygium. Like most of the patients show age in the age of 31 to 40 years, and we can say more females are prone to pterygium. From the above data, its incidence of the pterygium is highest 2/3 of the patient, 32.86% of fourth, or in the fourth decade, 35.71% in life, both males and females show pterygium. Discussion. In India, pterygium is a common problem encountered by ophthalmologists in their day-to-day practice. Though surgery is the treatment of choice, it is associated with high recurrence rate. Autologous conjunctival graft is a simple and effective procedure, and it does not involve loss of tissue. The low recurrence rate is attributed to the fact that normal conjunctiva acts as a barrier and preventing proliferation and advancement of the abnormal tissue towards the limbus. Amniotic membrane reduces recurrence by promoting conjunctival epithelialization, inhibiting inflammation, and suppressing subconjunctival fibrosis. Hence, the relevance of study comparing these two techniques. Conclusion. Pterygium is more commonly seen in third decade and fourth decades of the life in both male and female. It is more common among females. Incidence of pterygium is found to be more in those engaged in outdoor occupations, like a person which is exposed to more UV radiations in dry, hot environment, etc., etc. Unilateral pterygium is more common than bilateral pterygium. Nasal pterygium had almost 96% occurrence. In some patients, we can see double pterygium also. Graft edema is more common with conjunctival autograft as compared to the amniotic membrane graft. Graft edge recession is more seen among conjunctival autograft group. Loss of graft tissue was observed to be greater in amniotic membrane graft. Once patient developed post-operative infection in amniotic membrane group. Recurrence rate in the conjunctival autograft are 5.71% and recurrence rate in amniotic membrane graft is 11.43%. Recurrence rate between the two groups does not show any statistical significance. Okay. I conclude that both amniotic membrane graft and conjunctival autograft are equally effective treatment options for the pterygium surgery with comparable recurrence rates and cosmetic results. Either may be selected based on the patient characteristic and facilities of the ophthalmologist. Thank you, everyone.
Thanks, Dr. Divyanshu, for informative paper presentation. Next speaker, please.
A very good morning to you all. Myself, Dr. Ekta Karana, PG second year resident from GMC Kota. I am presenting my paper on primary open angle glaucoma in diabetes mellitus type 2. Introduction. Diabetes mellitus represents a significant public health issue which has become increasingly prevalent due to the changes and trends in the diet, lifestyle, and consequently the rate of obesity. The burden of diabetes on the healthcare system is manifest in many different ways. Diabetic patients require more outpatient visits, chronic medications, and are at risk for a number of systemic microvascular complications that result in end organ damage and associated complications like renal diseases, cardiovascular diseases, amputations, vision loss, and premature death. Vision loss from diabetic retinopathy represents one of the most devastating complications on the quality of life and is the leading cause of blindness in the working age and the economically active adults. In addition to retinopathy, the diabetes have been associated with a number of other potentially vision-threatening ocular complications including cataract, uveitis, and glaucoma. Glaucoma is characterized by pathognomic optic nerve changes which result in progressive vision field loss over time. Primary open-angle glaucoma is the most common form of glaucoma and is associated with a number of risk factors such as family history, African ancestry, and the elevated intraocular pressure. Glaucoma is also one of the main reasons behind the permanent blindness throughout the world. Data revealed that there are around 66.8 million people throughout the world who had suffered with glaucoma. Diabetes mellitus may also result in increased central corneal thickness leading to increased intraocular pressure. Diabetes and hyperglycemia is associated with glycation of lipids and abnormalities of lipid metabolism, which may increase the oxidative stress and promote the cellular apoptosis, the same mechanism by which the retinal ganglion cell layer loss occurs in the glaucoma. Aims and background. To determine the prevalence and risk factors associated with the primary open-angle glaucoma in the diabetic patients in a tertiary care center. Materials and method. My study included 100 type 2 diabetic patients that visited in the Department of Ophthalmology and Department of Medicine at MBS Hospital, Kota from 1st March to 31st August 2023. A written informed consent from all the patients were taken before start of this study. All type 2 diabetic patients above the age of 40 years with a history of progressive blurring of vision associated with redness, watering, ocular pain, and colored halos were included. Patients with any other surface ocular disorders, any corneal opacities, patients with history of ocular trauma, ocular infections like keratitis, uveitis, choroiditis, ocular malignancies, and patients with secondary glaucoma were excluded from this study. Then, a detailed history taking an external eye examination was performed as an initial evaluation of all the patients. Following examinations were done for the diabetes, included fasting blood sugar, postprandial blood sugar, and HbA1c levels were checked. Among the ocular examinations, we did the visual acuity using the Snellen's chart, intraocular pressure measurement using the applanation tonometry, detailed fundus examination was done, and gonioscopy was done using 4-mirror gonio lens. OCT for the retinal nerve fiber layer was done using the Zeiss HD OCT, and visual field tests were done using Humphrey field analyzers. Results. The diagnosis of glaucoma was done as per the raised intraocular pressure level, incidence of glaucomatous optic disc damage, RNFL loss based on the OCT, and visual field defects based on perimetry, and primary open-angle glaucoma was confirmed on gonioscopy. Intraocular pressure and gonioscopy was done in every case except the cases having active infections and the corneal surface diseases. Out of total 100 type 2 diabetic patients, 14 patients were found to be having primary open-angle glaucoma. Discussion. Diabetes mellitus is reported to be a possible risk factor for glaucoma. Zhou et al. Reported that diabetics have an approximately 1.4-fold increased risk for developing primary open-angle glaucoma. In the present study, most common glaucoma was primary open-angle. From present study data, it appears that there is a direct connection between the diabetes mellitus and the primary open-angle glaucoma. Different hypothesized biological links have been reported which confirms this relation. First, there is an evidence that chronic hyperglycemia along with the lipid anomalies have enhanced the neuronal injury risk. The second is that the different studies have found that eye of the diabetic patients lose the power to auto-regulate flow of blood, resulting in the decreased flow in the retina. This may result into hypoxia and expression of hypoxia-inducible factor alpha production, especially in the glucomata size. The third important explanation is the change in the connective tissue of the optic nerve head. It reduces the impedance at the trabecular meshwork and at the lamina cribrosa, leading in the increased intraocular pressure and increasing workload of the optic nerve head. Reports have shown that diabetic mellitus can worsen this remodeling and exaggerate the biochemical changes. Conclusion. Diabetes mellitus type 2 patients are at high risk for developing primary open-angle glaucoma, and glaucoma family history and retinopathy are the main risk factors for the primary open-angle glaucoma in the early years of diabetes. Early detection and treatment of glaucoma can prevent patients from blindness. The findings of the present study suggest the screening for glaucoma should be done in all the type 2 diabetes mellitus patients. This is a graph showing that out of the total 100 patients, 14 patients were found to be positive for primary open-angle glaucoma. The mean age of my presentation was 56.13 years. Thank you.
Thank you, Dr. Ekta. Please collect your certificate. Now we invite next speaker, please. Dr. Jagdish will present next paper.
Good morning. To the compare RNFL thickness in hypertensive patient on the antihypertensive treatment and normotensive by the using optical coherence tomography. Introduction. Hypotension following antihypertensive treatment is associated with the retinal nerve fiber loss, the altered autoregulation of the retinal circulation in the hypertension and hypotension leading to the hypoperfusion and ischemia of the retinal tissue. Patient on antihypertensive treatment, it was calcium channel blocker were used 60%, beta blockers 20%, and AC inhibitor 6.7%, and diuretic 3.33%. Systemic hypertension who were on treatment significant thinner peripapillary RNFL thickness. Aim and object. To compare RNFL thickness in hypertensive patient on antihypertensive treatment and normotensive control group by the using OCT. To the compare the RNFL thickness in the hypertensive patient different antihypertensive agent by using spectrum domain OCT. Method and material. This cross-sectional study was conducted at Tertiary Care Center. Patient diagnosis to hypertensive and age-matched normotensive were enrolled in the studies. Total 60 patient, 30% with the systemic hypertension, 30% with the normotensive above the 45 years were studies. Recording visual acuity with the Snell chart, intraocular pressure measuring Goldman applanation tonometry. Blood pressure measuring using the sphygmomanometer, systolic blood pressure, diastolic blood pressure, and pulse pressure measurement. Difference between the systolic, diastolic, and means blood pressure and intraocular pressure define ocular systolic perfusion pressure, ocular diastolic perfusion pressure, and means ocular perfusion pressure. Slit lamp examination done with apaciotomy slit lamp to the evaluate anterior chamber. Fundus examination with indirect ophthalmoscope and patient eye dilate with 1% tropicamide and pupil dilate more than 5 mm and signal stent more than 6. Photography of the RNFL finding will capture spectrum domain OCT. Results 30% with the systemic hypertension and 30% normotensive above the 45 years. Antihypertensive treatment by patient is the follow. The 80% on the calcium channel blocker and 6% of beta blocker and 2% AC inhibitor and other 1% is the diuretic AC inhibitor, AC receptor blockers and combination therapy. Correlation between the age and average RNFL thickness between the hypertensive and normotensive. The 45 to the 50 year age, the RNFL thickness in the hypertensive patient, the 107, and normotensive patient, the 113. 51 to 55 years age, the 103 in the hypertensive patient and 110 RNFL thickness in normotensive patient. 61 to 65 is the 95 in the hypertensive patient and 99 micron normotensive patient. Quadrant wise and average peripapillary RNFL thickness in the hypertensive and normotensive patient. The inferior quadrant, the 127 micrometer RNFL thickness in the hypertensive patient and 132 in normotensive patient. The decreasing the superior nasal and temporal quadrant. The average RNFL thickness in hypertensive patient is the 98.31 and normotensive patient the 103.51. The RNFL loss of the RNFL in the right eye, the superior and inferior quadrant, and the left eye is the inferior and temporal quadrant. Discussion: the maximum RNFL thickness was the seen the age the 45 to the 50 years and least the 66 to 70 years. There was no statistically significant difference in the RNFL loss when compared with gender in both groups. The RNFL thickness measuring the hypertensive group in the male was 98.19 microgram and in the female the 98.44 microgram. In the normotensive RNFL thickness in the male and female the 102.65 and 102.35 micrometer. 60% patient on the calcium channel blockers. The study by increasing the risk of the disc damage using the calcium channel blocker. Conclusion: study has the reported increased the RNFL loss with increasing age. Our result the show age group above the 45 year there was average 17.86 micrometer RNFL loss in the hypertensive and average 21.92 microgram in the normotensive individual. Surprisingly, it was seen that there was more RNFL loss due to the aging in normotensive groups. Thank you.
Thanks, Dr. Jagdish. Kindly collect your certificate. And next speaker.
Dr. Dinesh.
Okay.
Good morning, all of you. I am presenting paper on comparing the effect of bromphenic 0.09% QD to nepafenib 0.1% TID. And following cataracts are initial assessment of visual acuity and retinal thickness. Introduction. Cataract is a progressive disease and is the leading cause of blindness worldwide. Without appropriate surgical intervention, patients experience a steady decline in visual acuity which may lead to reduced physical function. Cataract extraction rank among the most commonly performed surgical intervention and markedly improve patient visual functioning and equality of life. The recommended approach for cataract removal involves extracapsular extraction, often performed through phacoemulsification, and followed by the placement of intraocular lens within the capsular bag. And topical non-steroid anti-inflammatory drugs are widely accepted as the standard treatment protocol, employed both before and after the procedure to manage inflammation and promote a complete and optimal visual recovery. Ocular surgery trigger an inflammatory response that result in heightened production of prostaglandin, and surgical trauma initiates the activation of phospholipase A2, which subsequently releases arachidonic acid from the cell membrane. COX-2 enzyme transfer arachidonic acid into various prostaglandins, and being the most significant, a key role in mediating the typical inflammatory response. Currently, these are two topical NSAID, which are namely bromphenic 0.09% ophthalmic solution and nepafenib 0.1% ophthalmic suspension, that have received approval for post-operative pain and inflammation management in a cataract extraction patient. Both of these medications claim to address ocular inflammation by serving as a potent inhibitor of COX-1 and COX-2 enzyme. उसके बाद patient and method. Participants were randomly divided in two groups, one receiving brompinec once daily and other receiving nepafenib. The treatment began 3 days before cataract surgery and continue until day 21st after surgery. Inclusion and exclusion criteria. Inclusion criteria: above 80 years of age, scheduled for unilateral cataract surgery with posterior chamber intraocular lens implantation, for whom no other ophthalmic surgical procedure. IUP more than 5 mmHg and less than 22 mmHg in steady eye. Agree not to have any other ocular surgical procedure in the steady or fellow eye within 15 days before the initiation of NSAID dosing or the throughout of duration of study. Exclusion criteria: non-hypersensitive brompinec or nepafenib or their component, non-hypersensitive salicylate or other NSAIDs. Use any ocular prostaglandin within 30 days before initiation of dosing with the steady NSAID or throughout the duration of the study. Treatment: the randomized participants were directed to begin using their designated topical medication, which was either brompinec ophthalmic solution 0.09% once daily or nepafenib ophthalmic suspension 0.1%. Results: study population 20 enrolled subject consisting on equal number of women and men with an average age of 69.9 years. Efficacy: here is comparison best corrected visual acuity from baseline to week 6 for both treatment group, brompinec and nepafenib. Efficacy: throughout the study duration, 90% of individuals in brompinec group maintain or saw an enhancement in their visual acuity, whereas in nepafenib group, this figure was 80%. The difference was not statistically significant. However, by the third week, the brompinec group conclusion. On this examination of individual receiving NSAID treatment after phacoemulsification and IOL implant, both brompinec 0.09% ophthalmic solution taken once daily and nepafenib 0.1% ophthalmic suspension administered 3 times daily were well tolerated and yielded favorable clinical outcome. The finding indicate that brompinec user experience less retinal thickness overall and demonstrate a greater improvement in best corrected visual acuity when compared to baseline.
Thank you, Dr. Dinesh. Please collect your certificate. And next presenter is Dr. Chandrapal.
Good morning, everyone. My topic is for today presentation: pterygium-induced astigmatism before and after surgery. Introduction: pterygium is a triangular encroachment of the bulbar conjunctiva onto the cornea, a clinical picture recognized from ancient times. It occurs in two forms. A true pterygium is a degenerative and hyperplastic process in which conjunctiva actively invades the cornea. A pseudopterygium is the result of an inflammatory process. When pterygium remains small, it gives rise no symptoms apart from slight irritation in the periods of inflammatory engorgement. The progression of a pterygium onto the cornea can lead to both significant corneal distortion and the development of large amount of corneal astigmatism. In advanced cases, the pterygium encroaches onto the cornea and may cause visual loss secondary to loss of corneal transparency within the visual axis. Yeah, irregular corneal astigmatism. Larger the pterygium, the greater amount of astigmatism, and removal of the larger pterygium exert the more significant changes in corneal astigmatism. Corneal topography, keratometry, and refraction detect all changes well. Successful pterygium surgery brings significant changes in induced astigmatism and improvement of vision. And of the study, to find out corneal astigmatism produced by pterygium, find out changes in corneal astigmatism after surgery, to determine the differences in mean corneal curvature before and after pterygium excision. Method of this study was done in Dr. Hassan Medical College, Jodhpur. This study period extended from January 2023 to September 2023. In this study, 44 patients with primary ocular pterygium in the age group 18 to 70 year were selected. Patient selection and inclusion criteria: patient with a primary ocular pterygium, age group 18 to 70 year. Exclusion criteria: recurrent pterygium, implant pterygium, previous history of corneal disease, previous history of intraocular surgery, eye trauma, contact lens wear, pseudopterygium, systemic disease like collagen vascular disorder. All the patients in the age group between 18 to 17 years with primary ocular pterygium who attended or outpatient department were selected. Relevant clinical history and data were collected and patients were ruled out according to exclusion criteria. Pterygium was graded depending upon the extent of corneal invasion as seen on slit lamp examination. Corneal curvature were measured using by keratometry. Corneal curvature value were recorded separately from horizontal and vertical meridian, and corneal astigmatism were documented pre-operatively. They are treated either with pterygium excision with primary conjunctival closure, yeah, pterygium excision with conjunctival autografting. On first post-operative day and after 1 month, automated refractometry and keratometry were done in operated eye, and changes in corneal curvature and astigmatism were noted. Corneal curvature value were recorded separately for horizontal and vertical meridian, and corneal astigmatism were documented pre-operatively. They were treated either with pterygium excision with primary conjunctival closure or pterygium excision with autograft. Table 1, grading and astigmatism. This table showing in fact the amount of astigmatism increase with grading of pterygium in each group. Table number 2 is showing that there is statistically significant steepening of horizontal meridian after conjunctival autograft, and there is no statistically significant changes in horizontal meridian and simple closure group. Table 3 showing there is a statistically significant steepening of vertical curvature after conjunctival autograft, and there is statistically significant flattening of vertical curvature after pterygium excision. Table number 4 is showing there is a statistically significant decrease of astigmatism post-operatively in this group. And table number 5 showing there is statistically significant decrease of astigmatism post-operatively in this group. Conclusion: to conclude, pterygium leads to a considerable effect on corneal refractive status, which has been measured in various studies by reflection, keratometry, and corneal topography. Astigmatism seen in patients with pterygium is mostly induced by the pterygium itself, and most of the time with the rule astigmatism. Pterygium surgery effectively decreases the cylindrical error and reverts corneal curvature towards normality, thus improving subjective visual acuity. These findings were noted in both conjunctival autograft group and simple closure. The amount of astigmatism induced by pterygium reduced after surgery. This present study verified that the size of pterygium increases, amount of astigmatism also increases in direct proportion. A successful pterygium surgery reduced the induced astigmatism. Thanks.
Thanks, Dr. Chandapal. Please collect your certificate. Next speaker. Yeah, Dr. Akshita will present the paper.
Good morning, everyone. Myself, Dr. Akshika Dhamija, second year resident at Dr. SN Medical College. I am presenting paper on demography and outcome of pediatric ocular trauma in Western Rajasthan. Childhood ocular trauma remains a prevalent cause of acquired blindness, inflicting severe and lasting visual impairment throughout a person's life. This results in considerable economic burden on society and profoundly impacts a child's psychological, social, and emotional development, raising concern about their future. Accounting for 8 to 14% of total injuries, childhood eye trauma differs from adult ocular trauma in terms of causative agents, evaluation, and management protocols. The spectrum of injury ranges from corneal surface abrasions to corneal and scleral perforation, with majority being preventable through simple precautions and identification of risk factor. Ocular injuries are classified into open type, open globe, closed globe injuries. Open globe injuries require immediate attention as an emergency. My current study aims to identify various causative factors of pediatric ocular injuries, implementing preventive measures in the population, assessing visual outcome in terms of pediatric ocular trauma. My aim is to determine the demographic profile of children affected by ocular trauma in terms of age, gender, father's occupation, residence of child, and place of injury, to identify causes and type of ocular trauma, and to evaluate short and long-term outcomes. My hospital study-based prospective observational study was conducted for a period of 1 year in Department of Ophthalmology, Dr. SN Medical College. My inclusion criteria are children less than 15 years with ocular trauma attending ophthalmology OPD or emergency, children with ocular trauma transferred to Department of Ophthalmology with or without primary management, children's guardian that are willing to give consent. I did a pre-op evaluation and ocular examination including history taking including name, age, gender of child, father's occupation, and residence of the child. Basically, details history was taken and detailed ocular examination in terms of anterior segment and posterior segment evaluation, USB B scan for perforating injury, gonioscopy for closed globe injuries, and evaluation of uncorrected and best corrected visual acuity. This is pediatric ocular trauma score, my parameter to evaluate the outcome. Some patients were given operative treatment, post-op management was done with adequate antimicrobial coverage, and post-op slit lamp examination was done, and visual acuity after 6 weeks was noted. This is my examination. Results were mainly boys were more affected than girls, 61% were boys, and mainly 73% of the rural population was affected. 68% was closed globe injury, and the most important is 52% of the trauma occurred around festivals time, especially Diwali and Holi. Mainly object causing injury mainly was wooden stick injury. This image is of wooden stick injury patient. And secondary firecracker injury around Diwali, next RTA, then rest others. Conclusion, child with ocular trauma comes in OPD 1 in every 15 IPD patients. Majority cases of pediatric ocular trauma are preventable, as wooden stick or firecracker injury is the major cause in Western Rajasthan, our developing country setup. Pediatric ocular trauma score is good predictor of outcome of pediatric ocular trauma. Reduction in pediatric ocular trauma by spreading awareness can lead to significant improvement in socio-economic development. Thank you.
Thank you, Dr. Ashika. Please collect your certificate. Next speaker. Dr. Gufran. Dr. Gufran, not available? So I think we have completed all the free paper presenter.
So in another 2 minutes or so, we'll start the session.
Dr. Vatsalya and Dr. Rajesh Malpani sir on dais. Today's first talk is the weight macam of orbital imaging by Dr. Vatsalya Venkatraman. So,
hello. A very good morning to one and all present here. To begin with, I would like to express my sincere gratitude to Rajasthan Ophthalmic Society as well as Jodhpur Ophthalmic Society for this opportunity. The Vade Makam is Latin for a manual or a guidebook. Today's talk is going to brief the audience on the basics of orbital imaging. I have no financial disclosures and no conflict of interests. So the three basic modalities of imaging for ophthalmic purposes include CT, or the computed tomography, MRI or magnetic resonance imaging, and the B-scan ultrasonography. Due to paucity of time, I shall be laying focus on the former two. So principle in brief, in computed tomography, the X-rays undergo attenuation as they pass through the tissues due to absorption of energy, which is determined by the atomic number of the major tissue constituent. When compared to plain radiography, wherein the X-rays pass through the patient to create an image directly on the photographic film. How is CT superior, or rather what are the drawbacks of X-ray is that in case of X-rays, the 3D structure is put on the 2D plane, which causes disturbing superimposition, and there is low sensitivity to small differences in attenuation, giving poor contrast. So how is now CT scan differing from it? So in case of a CT scan, the images are acquired by a rapid rotation of X-ray tube 360 degree around the patient, and the radiation is then measured by a ring of sensitive radiation detectors located on the gantry around the patient. The final image can be reconstructed in a 2D or a 3D manner from multiple X-ray projections. The measurements of different absorption values of tissues after their exposure to X-ray depends on the density of the tissues that it passes through. These absorption values are converted into grayscale units by preset formulas. Arbitrarily, the higher density areas are depicted as white, whereas low density areas appear black. They contain information from thin slices of tissues only and thus are devoid of superimposition. The result is a contrast resolution which is far superior to the projection of X-ray techniques. What are the advances in CT imaging that we have are the spiral CT and the multi-slice CT. So in case of a spiral CT, the X-ray tube rotates in one direction around the patient in the helical manner, while the table on which the patient is lying is moved in a to and fro manner. Larger areas of body can be scanned at once, but only one slice can be taken per area. An improvement on that is the multi-slice CT, where multiple rows of detectors per area allow simultaneous scanning of several slices of ever-decreasing thickness at the same time. So as an ophthalmologist, when would you like to order a CT scan? We would like to order a CT scan wherein we are suspecting orbital infections which have trespassed the septum or become post-septal. In case of palpable orbital masses, or in case of proptosis, orbital trauma, congenital orbital anomalies, suspected orbital spread of intraocular or ocular surface neoplasms, and in case of any unexplained proptosis, ophthalmoplegia, or ptosis. So how do you request a CT scan? So there are few particulars that is to be kept in mind when you order a CT scan or advise a CT scan. What is a slice thickness? So the slice thickness refers to the spatial resolution of the CT scan. Normally for the orbit, about 2 mm cuts are sufficient. Thinner the slice, higher is the resolution, but the drawback is higher is the radiation dose as well. In case of orbital apex or optic canal anomalies, we can go for a slice thickness which is lower than even 2 mm. Imaging plane, the routine ones are axial and coronal. In case of any specific floor pathologies, such as orbital floor fractures, a reformed sagittal view through the inferior rectus is beneficial. In case of optic canal pathologies, we can request for a plane which is at 30 degrees to the orbital meatal line. What are tissue windows? So tissue windows refers to the selection of a small range from a spectrum of orbital composition and tissue densities to decipher final details of that tissue. For example, if you were to order a bone window, any pathologies which is within the bone will get highlighted better than a soft tissue window. Lastly is the contrast enhancement. The imaging area of interest after intravenous injection of a radiological contrast medium will yield a contrast-enhanced image. Optic chiasma, pericellular region, extraorbital extensions of orbital tumors, vascular and cystic lesions, as well as optic nerve lesions are few ones in which contrast can be beneficial. What is the need for an ophthalmologist to interpret a CT scan? They are twofold. Primarily, the orbital disease accounts for a very small part of the radiologist's active or average CT load. Therefore, it provides him or her less opportunity to gain expertise on the subject. Secondly, an ophthalmologist has a better anatomical as well as functional knowledge of orbital structures and the patient profile. So we have an edge and over the radiologist in case of orbital lesions, and thus we must know how to interpret a CT scan. What are the components of the CT scan? So the demographic details, the patient data, type of scan, laterality, axial scan orientation, coronal scan orientation are things that I've already discussed. Technical parameters include size, thickness, Hounsfield units, which is the measure of the tissue density post the CT scan, the window width, the window level, which are both the parameters for the tissue window, table position, and the measurement scale for measuring the size of the lesion. So this is how broadly a CT scan would look. But in order to delineate where is the point of focus, we must always look at the lateral scout view. In the lateral scout view, the lesion would be well delineated, and thereafter we can go into the details of the lesion. This is how an intraocular foreign body would look inside. I'll just sum up fast. So this is a case of a dermoid cyst, wherein you can see that within the lesion it is a low density ethmoidal mucocele. This is a case of orbital trauma with a floor fracture along with a pneumoorbit, and this is post-surgery where you can see the plate intact. So because of paucity of time, I will just directly go to the point wherein we compare the CT with MRI. So CT versus MRI, what is the benefit? The CT has a quicker acquisition time, it's relatively economical, it's preferred for spotting calcifications and bony involvement, whereas MRI gives you a superior soft tissue differentiation. It has the benefit of having no ionizing radiation, and it's ideal for extraocular muscle, optic nerve, and orbital apex lesions. It is seen that CT and MRI both are equivocal in predicting extraorbital involvement, intracranial extension, and contrast enhancement. Thank you for your patient hearing.
Thank you, Dr. Vatsalya. Please collect your certificate.
Yeah, okay. I would like to ask you a few of the questions for our own benefit. One is that one must categorically know what are the contraindications for an MRI, and where do you should ask for MRI. So would you be elaborating on that?
So the chief contraindication for MRI would be if there is any kind of implant which is ferromagnetic in nature, and in those kind of cases, like for example, if you're suspecting in case of an orbital trauma a metallic foreign body whose constitution we are unaware of, then it would be better to go for a CT versus an MRI, because ferromagnetic can have a reaction in the electromagnetic external coil. That's the chief contraindication of MRI. And the advantages that MRI gives us over is a better soft tissue delineation. So in any case of any lesion which is not very well circumscribed or lies more preseptal in nature, an MRI would give a better tissue differentiation.
All right. So principally, MRI gives very little advantage over CT in orbit. Basically, only in lesions who are quite close to optic nerve we may have MRI with little more information than the CT. The other thing is that which I would have liked you to stress upon is that how to say that this particular cut is coronal cut, this particular cut is sagittal cut, and this particular cut is AP cut, because that's where the importance of ophthalmologist lies in diagnosing a particular lesion. So I think for the benefit of audience, if you can stress upon.
Sir, I do have a slide on that. If just for a second I can take you back on the three sections.
All right, I think in the interest of time then, yes. All right.
Yes, we have the section. So in case of a sagittal scan, as we can see, it can be recognized by the presence of only one orbit, sir, at a time, with the brain tissue above and behind it.
Correct.
Whereas in case of an axial scan, it can be recognized by the presence of both orbits in the scan with brain tissue lying behind it. And in case of a coronal scan, anteriorly the eyeball will appear full in size. When you come to mid-orbit, its size reduces till it disappears posteriorly, where you'll be able to see the extraocular muscles and the optic nerve.
All right, so this is pertinent to note, and especially in patients where we are dealing with orbital floor fractures and all, we particularly look for coronal sections. Similarly, whenever any orbital surgeon or oculoplastic surgeon, if he or she is looking for relationship of muscles with the tumor or any abnormal lesion, we would ask for a coronal scan, or we would look into the coronal scan. While AP scans are more useful for localization of lesion, in which particular quadrant a lesion is there and what is the extent of that particular lesion. And as you said, sagittal scan means single, S for S, single eye per scan is sagittal. Anteroposterior scans, when you have got complete detail of eyeball in your scan and brain tissue behind the eyeball, as you said. And in coronal scan, you are having coronal cuts of eyeball with brain tissue above and below. So, okay, thank you. Thank you for your presentation. Please collect your certificate from Dr. Malpan.
Dr. Rajesh Singh. I'd like to call our next speaker, Dr. Maya Hada.
She is not here. Abhi aa rahi hai wo.
So, our next speaker, Dr. Ravi Trehan, sir. He is speaking on SICS to CICS.
Control is with me. Control yahi se. Thanks ROS for giving me opportunity to speak on topic of my interest, SICS to CICS. Small incision cataract surgery, as we all aware of, but we have to move towards CICS, that is customized incision cataract surgery. Everyone is well aware of surgically induced astigmatism. When any astigmatism produced because of surgery, because of incision, that is surgically induced astigmatism, but I differ partly. Every incision do not induce astigmatism. If incision is on flat axis, then only this will induce the astigmatism, and if incision is on steep axis, this will correct astigmatism. Then the terminology is SIA is not there, it is SCA, surgically corrected astigmatism. Here very small equation of CICS. We are well aware that as SICS, if reduce SIA, results are undoubtedly better as we got in phaco. But in phaco, if we add the advantage of surgically corrected astigmatism, then the results are CICS, that is customized incision cataract surgery, and what we are supposed to move towards. Now, I'll share some of the tips to conversion of to CICS. Here, three situations are given. One diopter of pre-operative astigmatism at 180 degree in all the cases, but incision is differ in all the cases. First, pointer hai? This is moving, I think this will do the job. In first case, here incision is giving on steep axis, second flat axis, third askew. In each and every case, the results are different. So we have to use these results for our benefit. In my practice, I do not want every patient to be astigmatic at the end of surgery, because I observe and everyone must have observed that slight myopic astigmatism always giving better results than an astigmatic. Now, few tips are there. Size of incision, this certainly SIA will increase with the size of incision, and size in this surgery depends upon grade of nuclear sclerosis, which type of IOL we are supposed to implant, removal of nucleus in toto or we have to divide, or an pre-operative, pre-existing astigmatism. For determining steep axis, we have to mark the incision, and this marking of the steep axis should be done in sitting posture only, otherwise little bit haywire is there. Shape of incision, straight, easy to do, curved, and then chevron. Ease of doing is not there, but as far as control in astigmatism there, chevron is the best. One more type of incision, this is straight with radial cuts, posterior radial cuts, scleral pockets, and then inner entry. If we are giving 6 millimeter of straight incision with radial cuts, then any kind of nucleus can be removed with these scleral pockets. Depth, it should be 50%. If it is less, then chances of buttonholing is there, and if it is more, chances of fish mouthing is there. In both the cases, control of astigmatism will vary. Size of corneal tunnel, corneal part of tunnel should be more than 1.5, otherwise your astigmatism control is not under your control. Entry in anterior chamber and extension. Few observations what I have noted. If we enter with 2.8 millimeter keratome and then extension with that 2.8. In second instance, entry 2.8, fill the visco and then extension with 2.8. In third chance, 2.8 millimeter keratome entry, fill the visco and extension with 5.5 single entry. Astigmatism control is better in this case. Hypotensive, normotensive and hypertensive eyes will produce or correct different amount of astigmatism. But the entry of my choice is fill the visco in AC, 2.8 millimeter keratome entry and extension with 5.5. Fresh and sharp blades should be there. Pre-planned size of incision. No struggle in tunnel during lens delivery, since struggle will lead to stretching of tunnel, hence we won't able to control. So take our message, temporal, superiotemporal and superior incision induce different amount of astigmatism even with same size. And to start with, if you are not able to customize, at least start doing surgery from temporal incision. These are the some SIA calculators are available online. You can calculate your SIA. Thank you.
Very nice and practical talk, Dr. Trehan. So, in nutshell, you advise giving incision like you generally use astigmatic axis to make incision, or you make incision superiorly or temporally, like what is your preference?
Preferably, most of the time, more than 90%, it should be on steep axis.
Okay. So you shift your position according to the steep axis. Always used to.
My stool is revolving like this. And microscope is also revolving like.
Yes. So sometime when patient is having very prominent eyebrows and eyeball is quite sunken, then it may be little difficult to make tunnel superiorly.
But there,
with experience,
in 10% of cases I go temporal.
You go temporal.
In those 10% cases.
Right. So if anybody wants to ask any other questions, then it is fine, or we can move.
Pardon? Oh. In some of the cases when grade 5 cataract is there, and if I am not able to go on my desired axis, then I try to control that with 2 sutures, not single, 2 sutures, because that will control the astigmatism mainly. And rather, if some VIP is coming and grade 5 cataract is coming, I generally don't shift, because then I do superior incision because of redness, what we are facing a lot of times. and then two sutures equidistant, that will reasonably control of astigmatism. And I already mentioned I don't want any astigmatic, I want little myopic astigmatism at 90 degree. Most of the time my target is minus 0.75, 90 degree, and more than 60-70% cases I got them and results are as good as any EDOF.
And one more question is that in some of the cases where nucleus is quite hard, so would you prefer applying a lot of force through a smaller tunnel or size incision?
I already mentioned no struggle. My technique is viscomat above and below the nucleus, and I divide with vectis behind the nucleus and iris repositor above the nucleus, or I can use keratome also for cutting. Keratome, cystitome, sorry, cystitome for this. But no struggle in tunnel during lens extraction, because that certainly will stretch the tunnel and things will be not under your control.
Correct. Thank you, sir. Please collect your certificate from Dr. Mukesh Sharma, sir. Now I will invite Dr. Mukesh Sharma, sir, for his key. Dr. Maya, your presentation is ready? Yes. So, Dr. Maya is presenting on periocular trauma, challenging case bucket. Dr. Maya.
All of you. Sorry for the delay. I'll be speaking upon challenging case scenarios in periocular trauma, and there will be a learning point from each case. So the overview of my presentation is, I'll speak upon the retained orbital foreign body, subperiosteal hematoma, orbital floor fracture, and traumatic globe luxation, and the delayed repair of the lid laceration and canalicular tear. So this lady presented to me with a recurrent eyelid swelling of the right side associated with purulent discharge for last 3 months. And she was being treated for diffuse cystitis somewhere, and on careful history, there was a history of trauma while cutting the bubule stem 4 months back. So I suspected a retained orbital foreign body, which was confirmed on MRI. You can see a linear hypointense lesion on the superolateral orbit, that is a linear foreign body. And because the entry wound was not visible, it was lying in the superior fornix, and it was removed from the superior fornicial approach. So the tip learning point from this case is we should have high index of suspicion whenever there is a persistent inflammation or discharging sinus to rule out any retained organic foreign body in such cases. This young boy presented to me with left eye proptosis. He had a history of fall 2 weeks back, following which the acute onset proptosis occurred. So on imaging, a hypodense collection was noted just beneath the orbital roof. You can see here above the globe, which is compressing the globe downwards. So because the globe was displaced downwards and the movements were also restricted, we planned As an OPD procedure, we did a needle aspiration of this subperiosteal hematoma. I cannot move the cursor here. Okay. So around 7 ml of the altered blood was aspirated, and the proptosis spontaneously subsided then. So the tip is that a simple technique like needle aspiration can be helpful in such cases of subperiosteal hematoma if it is significant. Now the third case was a young boy who presented to me with diplopia and vomiting for last 3 days. He also had a history of trauma with a cricket ball, and on examination there was some restriction in the vertical gaze on the left side. And because there was a trauma history and then movement restriction, so I suspected floor fracture with inferior rectus entrapment, and that was confirmed on CT scan. As you can see here, there is a trapdoor kind of fracture on the left orbital floor. So typically in children, that is called as white-eyed fracture, and it may be associated with oculocardiac reflex, in which because of the muscle entrapment, patient may have bradycardia, vomiting, and double vision. So the release of the inferior rectus muscle was done along with the floor reconstruction with porous sheet. So we need to take an urgent intervention in such cases where there is a white-eyed fracture and inferior rectus entrapment in pediatric age group. Now this 1-month-old neonate presented after a fall from bed, and you can see on the right side the whole globe is luxated out, and there is a severe congestion of the eyeball and the lids are retracted back. So it was an emergency, and if we have waited for some time, then he might have lost his vision. So urgent intervention was done under general anesthesia, and tarsography was done, globe was reposited, and he gained his eyeball and movements and vision back. So a suture on time saves 9. So such simple procedures can save vision in such cases. Now lastly, I'll speak upon the delayed presentation of eyelid laceration. For example, this case was a RTA repaired by a plastic surgeon. However, the lids were left unsutured, saying that there is a tissue defect and it cannot be repaired. However, on attempting tarsography, we were able to oppose the tissues, and in the second sitting, we were able to do the lid reconstruction by after scar excision. So the lower lid was directly opposed, and the upper lid, I had to do a lateral cantholysis. After that, I was able to oppose the upper lid also. So my tip for such cases is that meticulous anatomical alignment after a scar excision can be achieved even in delayed presentation, and eyelid are elastic tissue. Rarely there is any tissue loss. And this was also a delayed presentation of a dog bite associated canalicular tear, and this was his distal canalicular tear. So here we have to locate the distal cut end of the canaliculus. So I inserted the probe after dilatation, and here we can see the canaliculus is avulsed right at the attachment at common canaliculus. So it's very distal, and it's difficult to locate sometimes. So I injected a colored fluid from the upper punctum. So after that, I was able to locate it right underneath the caruncle. You can see the shiny epithelium rolled out margin of this distal cut end that was confirmed with the probe. And in high magnification under microscope, it is easy to confirm it. And to maintain the proper alignment, we put a monocanalicular silicone stent which is self-retaining. So I inserted it from the punctum and then retrieve it from the proximal cut end. After that, it is important to achieve a meticulous pericanalicular approximation. So this is how the stent was inserted. Then the edge which was beveled, it was inserted into the distal cut end, and then the tissues were approximated with 6-0 vicryl first. We can also place, like pre-placement of sutures can be done prior to insert the stent, but sometimes in the distal canalicular injuries, I find it really difficult, so I place the sutures only after putting the stent, and then 2-layered closure was done. The skin was closed with the 6-0 silk suture. The tip from this case is that canalicular repair should also be attempted even if the presentation is little late, and injecting colored fluid provides good assistance in located medial cut end. So to conclude, I'll say that ophthalmologists must be aware of the clinico-radiological features of trauma-related periorbital emergencies for prompt management and better outcomes. Thank you for your kind attention.
Very nice presentation, and you have highlighted some of the important steps in traumatic lid repair and periocular repair. So I think those things should be kept in mind. If any of you want to ask some question to Dr. Maya, you are most welcome. Yeah.
In case of the first case, wherein there is a suspected organic retained intraocular foreign body, do you always prefer MRI over CT?
Usually in case of trauma, CT is the one which is usually done, but the sensitivity of picking a wooden foreign body, especially in case of CT, is variable because it depends upon the air content and how old is the foreign body. Sometimes it may be missed on CT. So MRI is the preferred modality in those cases.
Dr. Maya, please collect your certificate from Dr. Vatsalya. Now I will invite Dr. Mukesh Sharma sir for keynote address of this session. So transconjunctival orbital surgery.
So good morning everyone. Today I shall be speaking about transconjunctival orbital surgeries. When we talk about orbitotomy, there are various approaches to orbitotomy like anterior orbitotomy, which is transcutaneous or transconjunctival, then deep orbitotomies which can be transconjunctival also, lid crease, standard stellaride, etc. So saga of orbital surgery, it has been changed in recent time. Previously, all orbital surgeries used to be considered as a surgery done under dark, very less visualization, and they were guided only by the tactile sensation of finger of surgeon. Now we do orbital surgery almost under complete visualization. They are done under surgical microscope with the aid of endoscope or wide navigational method. Generally nowadays we all prefer doing surgeries through a very smaller, less visible incision like subconjunctival or canthotomy or cantholysis incision. But as it is the case in small incision cataract surgery also, incision should be adequate. It should be small but adequate. You should not be struggling through your incision. And of course, it should be cosmetically superior with lesser dissection, less bleeding and lesser morbitotomy. So whenever we attempt any orbital surgery, we do a careful planning. A very important aspect is you have to arrange for all the tools which may be required like cryo, diathermy or bone cutting saw, etc. You should take a good consent involving damage to various nerves and muscles, etc. Though the incidence is quite less, but one must take consent. A good radiological assessment is of paramount importance. Then the incision location. It has to be located on the size of tumor. Also, it should be adequate sized and cosmetically good. And you should be able to negotiate the barrier safely through your incision, like extraocular muscle, nerves, etc. And one must always have good post-op care and ICU backup if required. So, this is one case. This particular case had intraconal tumor. This is the tumor, and these are anteroposterior cuts. And in coronal cut, you can see it is located supratemporally, and just a minute. So you can see it is located between superior rectus. This is superior rectus muscle, and this is medial rectus. So pre-operatively, we have looked upon it, and we have decided that we can remove this tumor. This is located between two muscles without disinserting any muscle and through the subconjunctival approach. So with this background, we took the patient under general anesthesia, gave subconjunctival adrenaline. Then this is RF cautery which is being used. So all these surgeries now are virtually bloodless or very little blood loss if it is there in these surgeries. So once we have made the conjunctival incision, we have enlarged it, made incision in the tenons also, hooked the medial rectus. This is the medial rectus. We know that tumor is there between medial rectus and superior rectus. Now we are dissecting on. This is superior oblique, which is also hooked. And we have reached onto the top of tumor with careful dissection. This is the tumor top. After release of adhesions all round, a cryoprobe is applied, and with gentle rocking and pulling motion, tumor is pulled up. So this is a hemangioma which was very easily removed through an appropriate incision and with virtual no bleeding through transconjunctival approach. Now again, when we plan a tumor, this is relatively large tumor. You can see here tumor is very large and it is going beyond the medial rectus also and extending quite deep into the socket, and it is going quite deep. So we thought of disinserting medial rectus so that there may be easy delivery of tumor. So we have tagged the medial rectus as it is done in any squint surgery, disinserted it, then dissected the tumor, again applied the cryoprobe and removed it in toto. Cryoprobe acts as a third hand for all orbital surgeon, and it gives very good pull without damaging the vital structure. Now yet another case where transconjunctival orbitotomy was done. Here tumor was located in inferior orbit. So you can see tumor, this is the tumor inferiorly. So again subconjunctival xylocaine was injected, and with RF cautery we have dissected out, and we have reached onto the top surface of tumor. With meticulous dissection all over, all the adhesions were broken, and these are some of the nerve twigs which are attached onto the tumor. So they are cauterized and then cut. Then after releasing, again cryoprobe is applied, and with gentle rocking motion, tumor is delivered out. So with the careful planning of incision, one can take out tumors without creating a significant morbidity and any complication. So this was a neurilemoma which could be taken out again through the transconjunctival incision. Sometimes we need to cut the bone also if the tumor is located deep inside the apex and you cannot really dissect out tumor from anterior aspect. So this is done through canthotomy and cantholysis, and we have reached onto the lateral orbital wall. This is Stryker saw which is being applied here. So two parallel incisions are made onto the lateral orbital wall, and then this part of bone is removed with the help of bone ronger, and this is the tumor you can see. So periorbita is cut, and again the cryoprobe is applied, and tumor is taken out in toto. So it is important to take out tumor in toto without any breach in the capsule. This was multi-lobe tumor actually. So this is post-op. You can see virtually there is no swelling and few sutures for canthotomy and cantholysis. So for any orbital surgery, meticulous assessment is essential. There is no uniform scheme. You have to vary your surgical planning in each case. You have to have all the armamentarium ready. Sometimes you may require bone cutting instrument with you, and also you have to prepare for worst. You have to be prepared for severe bleeding. You should have arrangement for BT, blood transfusion. Rarely you may require to shift patient to ICU, so you must have some licensing with a good ICU hospital where patient can be sent if needed. And a thorough consent is required for every situation. But generally, it is a very safe surgery with very few complications nowadays, and seldom we require to actually need these things. Thank you for your patience hearing.
Thank you, Dr. Mukesh Sharma, for such a nice talk. Any questions from audience?
Just take care of medial tumors and optic nerve.
See, medial tumors are most difficult tumor to remove because there the space is very less in medial orbit, between medial orbit and eyeball. Laterally, we have got good space. So there, if the tumor is large, then sometime we need to disinsert the medial rectus. Similarly, if we want to reach up to the orbital apex for optic nerve, as we do in optic nerve sheath fenestration also, we disinsert the medial rectus because that gives us some space to work upon. And if tumor is located right at the apex, then instead of going from medial approach, one can even go from lateral approach, remove a large piece of bone so that one can directly visualize the tumor and remove it. So both the approaches are open, either to disinsert muscle and go from medially, or to remove a large piece of bone and go from lateral aspect. But they are difficult tumors to be removed.
You're taking care of pupillary reactions during the surgery. You're looking at the pupillary reactions, or
of course, that's why these surgeries are always done under general anesthesia, because sometimes we know that we do this surgery under general anesthesia not because of pain but because of pupil. We want to conserve the pupil. We do not want pupillary dilatation due to anesthetics agent. So that's why surgeries are always done in general anesthesia, and we keep on checking pupil intermittently. Pupillary dilatation may be there because of two reasons. One, when you are working close to optic nerve, you may endanger optic nerve and pupil may be dilated. More common than that is the damage to the ganglion, inferior ciliary ganglion, which is there in the mid orbit, not at the apex of orbit, and one can damage ciliary ganglion. By that you can have enlarged pupil, but the vision may not be affected.
Okay. In case of the hemangioma, didn't you need to tackle the feeding vessel?
No, sir. Generally, these are cavernous hemangiomas, and they do not have a large feeder vessels.
Okay.
So those can be tackled off without even worrying about that. But in AV malformation, we should always look for a feeder vessel. We should sometime we do Doppler, and we find feeder vessel coming from cranium. Yeah. So those are very difficult cases, and generally we tend to avoid them.
Okay.
Doing.
So what is the ultimate approach to those type of tumors?
There you have to have then cardiovascular surgeon available to you there, so that those feeder vessels sometimes they are coming from inside the brain also. So those feeder vessels need to be ligated or need to be dealt according to their vitality. So that's why these are difficult things to be done.
Can you be deceived sometimes? Can you be deceived sometimes? That looks it is.
Nowadays, with time, I have burnt my finger in one case wherein I opened and it was torrential blood coming from everywhere. Yeah. And with great difficulty, I could stop the bleeding by ligating all over. And then I had to send the patient post-operatively to a cardiovascular surgeon. So now with those hard-learned lessons, we do Doppler and all in all.
Thank you. Thank you. Okay.
Thank you, Dr. Mukesh Sharma.
I'll call next speaker, Dr. Anil Goel, for his approach to a case of headache.
Good morning, everyone. It's pleasure to be here in Jodhpur. I completed my post-graduation from Jodhpur. I was lucky to have Mukesh sir as my teacher. Today my topic is approach to a case of headache. Headache is one of the most common presenting complaint in the eye OPD. Every eye specialist has to deal headache patient in their OPD in daily basis. Headache is a vast topic, so I will discuss only the ocular causes of headache. So approach to a case of headache in eye OPD. We have to take history in detail, especially ask about the profession of the patient and the screen time. Then we have to do local examination, then measure visual acuity and tonometry. We should do the torchlight and slit lamp examination, dilated fundus examination. On the basis of history and examination, we should make diagnosis, and if the cause is ocular, we should treat, and if the ocular cause is not there, we should refer the patient. So in a case of headache, history is very important. It includes questions about the headache's characteristics, the location of the headache. It may be facial, frontal, temporal, occipital or generalized, duration of the headache, severity of the headache like mild, moderate, severe, the onset of headache, it may be sudden, gradual, the character of the headache like throbbing, constant, intermittent, pressure like headache. There may be exacerbating and remitting factors like light, sound, odor, and the associated symptoms may be there like nausea, vomiting, fever, rhinorrhea, redness of the eye, and visual symptoms. We should do local examination. It includes around the eyes by the torchlight. Especially look for the stye, signs of herpes and prominent temporal artery. We should note any deviation in eyes, squeezing of the eyes, frequent blinking, photophobia. Detailed slit lamp examination should be done to rule out uveitis, angle closure, glaucoma, etc. If the headache is mild to moderate in severity and frontal in location and bilateral, the most common ocular causes are like refractive errors, convergence insufficiency, presbyopia, and digital eye strain. Headache due to refractive errors like hypermetropia, astigmatism, and sometimes due to incorrect glasses. Age is usually less than 20 years. The clinical features are recurrent and mild headache, absent on awakening and aggravated by eye work. There may be ocular fatigue, discomfort, lacrimation, blurry vision, inability to keep eye open. The treatment is by the correction of refractive errors. Headache may be due to convergence insufficiency. In that case, visual acuity might be 6/6. It is more common in young adults. The clinical features are recurrent and mild headache, absent on awakening and aggravated by prolonged near tasks. There may be ocular fatigue, discomfort, lacrimation, diplopia, blurred vision at near work, and the typical complaint of the patient is the words seems to float on the page and there is frequent loss of place while reading. And the treatment is convergence, exercise and orthoptic therapy. And sometimes headache lead due to presbyopia. The age of onset is around 40 years in emmetropes and it is earlier in hypermetropes. The clinical features are again headache is recurrent and mild, and it is absent on awakening and it develops on near work. There is history of blurring of near vision. The typical complaint is need to near work from progressively greater distance. The treatment is corrective progressive glasses. The digital eye strain is very common in this era. It is very common in children and young adults. There is always history of prolonged screen time. It occurs at any age group. The clinical features are blurred vision, inability to keep the eye open, ocular fatigue, discomfort, lacrimation, burning, dryness, redness, irritations, and gritty sensations. Due to long sitting postures, there may be backache, shoulder pain, neck pain, and stiffness. For the treatment, we should advise about the 20-20-20 rule, frequent use of lubricants, screen contrast and room lighting should be adjusted, and we should advise about the anti-glare glasses. If headache is non-specific in character and generalized in location, we should always evaluate dilated fundus of both eye. If there is arteriolar attenuation, focal irregularities, retinal hemorrhages, exudates, we should check BP. If it is raised, we should refer to the physician. If papilloedema, we should refer to the neurologist for further investigation and management. So, the take-home message from this presentation is, headache is one of the most common presenting complaint in IOPD. It may signify serious intracranial problem. In IOPD, headache patients come directly or referred by our colleague. We should take detailed history, especially ask about profession, screen time, and we should do cycloplegic reflection and thorough eye examination. If any eye problem is found, we should treat that, and if there is no ocular cause, we should refer the patient to the concerned physician. Thanks for patient hearing.
Please collect your certificate from Dr. Rajesh sir. I'll invite Dr. Mukesh Sharma sir for his talk on ICL pearls.
So this is primarily a sponsored talk, but I would be highlighting certain important features. And the money for this sponsored talk has gone for towards organization of this conference only. So disclaimer, I have no interest. So ICL are also known as implantable Collamer lenses. They are done whenever LASIK is not feasible. And I'll be briefly telling you about where these can be done. So in initial patient assessment, patient age should be more than 20 years, refraction should be stable, and they can be done in myopia up to 18 diopters and hypermetropia up to plus 10 diopters. Primary candidates are those where LASIK cannot be done. So in thinner corneas, you can do ICL. Also in suspicion corneas where you can think patient is borderline, ICL can be done. It is better suited for dry eye patients than LASIK, but in very severe dry eye, we try to avoid this also. And also ICL, it do not have any concern for like any flap related weakness on the cornea, etc. So it is suited for those patients who want to do sports activity, etc. So these are some of the important preoperative measurements which should be done. One very important aspect in inclusion criteria of ICL is that patients should have 2.8 millimeter or more of AC depth from natural lens to endothelium. So if you are checking AC depth from a routine instrument from epithelium, corneal epithelium to lens, then you have to reduce the corneal thickness. So 2.8 is the criteria below which one should not do ICL. Also in preoperative workup, beside doing this thickness test, one should also check for angle because ICL goes at the angle, flange of ICL. So any glaucoma suspicion patient, ICL should not be done. And also one should take specular count in account. If specular count is low, then also ICL is not recommended. So this we have already discussed. For hypermetropic ICL, the guideline is you should do it in at least 3 millimeter of AC depth should be there. And in hypermetropic ICL, peripheral iridotomy is always done before doing ICL, while in myopic ICL, with the advent of central hole in this ICL, which is known as EVO ICL, the PI is not recommended, but in hypermetrop, still PI is mandatory. White to white measurement, it's a very important parameter in ICL measurement, and there are 4 sizes of ICL which are available, and they are chosen depending on the white to white measurement and AC depth. White to white should be taken, should be confirmed by a digital caliper, because there are instruments which give you varied reading of white to white. If you are doing white to white from OCT, it will give you lesser white to white reading than if it is done with the help of Pentacam. So we take finally digital caliper, and its values are taken as the correct value, and generally mid-limbal values are taken. So there are 4 types of ICL sizes which are available: 12.1, 12.6, 13.2 and 13.7, and they are chosen based on the white to white diameter. Generally 1 millimeter larger than the white to white size is chosen. Suppose white to white is 11.2 millimeter or 11.3 millimeter, then you choose 12.6 millimeter size ICL, but your company helps in this and they guide you which ICL is suited for a given patient. So this is the digital caliper which is used. And there is an online calculator also. You can do it yourself or you can take help of company people. So when we talk of surgery, it is done under topical anesthesia. This is a brief video of ICL. So loading is important here in the cartridge. First you fill it with the saline or BSS, then you inject methyl cellulose. You don't use here any other substance. You rely on methyl cellulose. ICL is taken on the top of this swab which is there, loaded in the cartridge. There is a central hole here in this flange, and this has to be kept towards your right hand. And there is a hole in trailing flange which has to be kept towards your left hand. Then once it is loaded, you pull the ICL from other instrument and then load it onto this injector. Then you go to the patient's eye. You have to be very careful while making a stab incision, because you are dealing with a clear lens and you do not want to injure the clear lens and create cataract. So you have to be very guarded while making initial nick. You should not insert your keratome with the force. Then we require to make 3.2 millimeter main port incision. Initially you can make 2.2 and then enlarge it to 3 or 3.2. And once you have done, then you insert your ICL with the help of injector. Initially it should be slow till you see the alignment of holes. If they are proper, then you can push it, and then you can place your flanges underneath the iris and your surgery is done. So it's a simple surgery, very low learning curve is there, and very, very good results. Patient satisfaction of ICL is much more than with the laser, LASIK and SMILE and PRK, but suitability of patient is of paramount importance. Thank you for your patience hearing.
I'll call our next speaker, Dr. Sunil Khandelwal. He's talking on AGV in refractory glaucoma.
Good afternoon all. Today's my topic is importance of AGV in refractory glaucoma. Forward कैसे होगा?
Audio visual.
Not forward नहीं हो रहा. Next नहीं हो रहा है. Refractory glaucoma is defined as uncontrolled intraocular pressure with evidence of optic nerve and or visual field deterioration despite maximally tolerated anti-glaucoma medications in a previously failed non-certain surgical treatment or a high risk of trabeculectomy failure. Different modality has been described to treat the refractory glaucoma, like glaucoma drainage devices, cyclodestructive procedures, or trabeculectomy with antifibrotic agents. The success rate of AGB in refractive glaucoma is around 60 to 82% at 2 years and 49% as in 5-year follow-ups. I'll discuss few cases where I did AGB in refractive glaucoma cases. She was a 65-year-old lady, came to our hospital with complaint of dimness of vision in both eyes. On examination, her visual acuity in the right eye was finger counting 1 meter. In the left eye, it was PL inaccurate. So IOP was 32 in the right eye. In the left eye, it was 40. On slit lamp examination, the right eye cornea was decompensated with ACL was there. And on examination of fundus, it was advanced glaucoma. So we started her on anti-glaucoma medication. The IOP came down to 12 mmHg. So we planned optical PK with IOL explantation. But after surgery, the IOP raised to 38 mmHg in the right eye despite full topical and systemic medications. So we planned AGB in this case, pars plana AGB we did. So this surgery, after doing placing traction suture, then conjunctival dissection was done, and cautery done, and tube is placed around 8 mm posterior to limbus, and it is sutured with 90 nylon. After that, pars plana vitrectomy done, and tube is placed around 5 to 6 mm into a vitreous cavity, and scleral patch graft then placed over the tube, and it is closed. There was another case where I did AGB in silicon filled eye. A young male came to our hospital with complaint of dimness of vision since 2 days in the right eye. He was diagnosed with retinal detachment in the right eye. He had a history of buckling done 6 months before, so he was operated for RD. PPV with endolaser with SOI was done. Post-operatively, IOP raised up to 40 mmHg with full medications. So 2 weeks later, we planned partial oil removal, but pressure was still high. So after 1 month, the complete removal of oil was done. The pressure came down, but after 1 month, again re-RD happened. So again, VR surgery with silicone oil implantation done, and again the IOP raised to 38 mmHg. So we planned AGB in this case. So same after conjunctival dissection. Tube is placed same 8 mm posterior to the limbus, and anchored to the sclera with 90 nylon. And in this case, I used corneal graft to cover the tube, and AC entry is done around 0.5 mm posterior to limbus, and tube is cut around 2.5 to 3 mm around into the AC. It was placed. And it is sutured then. Thank you.
Nice presentation, Dr. Sunil. So, one question. You do AGV in virgin cases also where no previous glaucoma surgery is done, or you
Like, definitely in NVG cases, it's better to do AGB compared to this. Even silicon-induced glaucoma, also the AGB works better than.
So my question was related to your silicon filled eye only, because there the no glaucoma surgery was earlier done.
So trap does not work in these kind of eyes because oil actually blocks the ostium. So that is the reason.
All right. Thank you.
Yeah, thank you.
Please collect your certificate from Dr. Malpani.
Next speaker, Dr. Vishweshwaran. He is talking on tricking the tricksters.
Good morning, everyone. So today I'm going to be talking about tricking the trickster, in other words, a malingerer. So malingering is also known as a non-organic or a functional visual loss, and it's basically defined as a willful alteration of subjective symptoms and evaluation and responses to evaluation. So basically there's a motive for a malingerer. It could be some kind of an emotional stress, some psychological condition. Sometimes it could be even a financial gain. So usually we see this in people in the second decade, sometimes even third, rarely older patients. It must be a diagnosis of exclusion. So unless and until you have evaluated the patient completely and you're damn sure that nothing else is wrong with the patient, you must not label somebody as a malingerer. The ground rule is no confrontation of the patient. You have to be kind. This requires a lot of sensitivity because you really don't know why the patient is doing whatever he's doing. And always remember, placebo treatment works beautifully in such patients. So I'll just list a number of tricks to identify these malingerers. First, observe the patient thoroughly. So you could line up a set of obstacles in the path of the patient, and usually these guys move very fast. They purposely try to bump into objects. Blind patients usually respond to auditory clues. They try to look in the direction of sound. And they also try to establish an eye contact in the direction of the sound. But a malingerer will never do that. He will try to always avoid eye contact. Some of them even dress up as famously blind people because they feel that they need to look blind and act blind. So they might wear sunglasses. Second, just look at the pupils. Obviously, if there is an optic nerve condition, you will have an afferent pupillary defect. But what you need to remember here is in cortical blindness, the pupils will be absolutely normal. Optokinetic nystagmus, as all of us know, is an involuntary response to moving horizontally or vertically visual stripes. So what one requires is just a level of acuity that sees or resolves these stripes. So once you have an optokinetic nystagmus, it means your vision is around 20 by 400. And sometimes these patients refuse to look at the optokinetic drum. So in such a case, what do you do? So you'll have to force them to look at the drum. For that, you just fog them with +3 diopters. And once these lenses are placed, the patient has nothing else to do but to look at the optokinetic drum, and an involuntary response is going to be generated. You can make them do proprioceptive tests like looking at the hand or making them touch the tips of their fingers, because this doesn't depend on vision at all. And surprisingly, blind people are able to do this very well. You could also place a mirror in front of the patient, rock it back and forth, and involuntary nystagmoid movement is generated. And this means that the patient definitely has a vision better than hand movement. You could also surprise them by writing some kind of text, some words. It could be funny, it could be offensive. Abuse works very well. Visual fields are quite typical. So they could have tubular ones, you could have a spiral visual field, sometimes absolutely random, non-specific defects, and rarely a cloverleaf defect also. Stereopsis also works very well. We could use the Titmus chart. If they are able to identify the 6th dot, it means their vision is around 20 by 50. If it's the 8th dot, maybe around 20 by 25. So basically there's a chart that has been made by Levy and Glick. So this associates stereopsis with visual acuity. You could use the duochrome test, the overlay. And basically the duochrome works on the principle that the right glasses, I mean, you give the patient a pair of red-green glasses and you make them look at the overlay. So the the red glasses will help you watch only the red portion of the overlay, and the green helps you watch only the green portion. So if you switch the orientation of the glasses and the patient is still able to read, it means he is malingering. And of course you have prisms. So you could use a 4 prism diopter base in prism in front of the bad eye. So what this prism does is it generates a refixation, generates a movement towards the apex of the prism. And once you remove the prism, there will be a refixation movement. So this doesn't depend on the visual status at all. If a person has vision, this is going to happen. That's it. Thank you.
Thank you, Dr. Vishweshwaran. It was a very nice presentation. Yeah, can you take up 1 or 2 questions? So, any question from the audience? Yeah, Dr. Maya.
We frequently encounter such patients in, for the medical visually handicapped certificate. So, is there any way to identify a person who is having low vision, like he's reading till 6:36 or 6:24 while your ocular examination is absolutely normal? What is your take on that?
Yeah, so one common condition is accommodative spasms. There are a lot of these patients who might actually have accommodative spasms. They might not really be malingering, and we label these people as malingerers. So
No, her question is entirely different. There are a set of patients who malinger to take advantage of government
So
rule.
you're sure that they're malingerers and their vision is 6/36?
See, we cannot be sure. Like our ocular examination is perfectly normal. There is no
Okay.
refractive error. Like your foveal thickness absolutely is right, and everything is right. And they can you give them a doubt of amblyopia for some reason? Like if they are reading for 6/24 and your ocular examination is normal, is there any way by which you can diagnose that it's not that low? It may be 6/12 or 6/9. So is there?
Yeah, so that's what. So what happens is a lot of these patients with accommodative spasm present like this typically. Like you might not have a refractive error, everything else seems to be normal, but the patient is still not able to read. So for that, you really need to, usually a cycloplegic refraction might not be enough. So in such a situation, unless and until you atropinize them and you call the patient back after a couple of weeks, you will not be able to identify the refractive status accurately. Because even if you try to refract them normally, regularly, whatever you do, you might not be, all patients might not end up with a refractive error. So one way to do it is atropinize them, eliminate that amount of accommodation, and then ask the patient to come back. Even after that, if you feel the patient is not, then you will have to definitely try to evaluate him for malingering, use all these tricks. And then if he's, I'm sure one of them, because there are many of them, so at least one of them will reveal this.
These tricks, actually, I think it's more suitable for, differentiating a blind from a non-blind. Like
Actually, one test could be what Dr. Maya is asking is that typically a medical college teacher has to give a certificate,
Okay.
and patient tell lie to obtain that certificate to get job.
Okay.
Now patient is saying that he cannot read beyond 6:24, and the clinician has got strong suspicion that patient is telling a lie.
Okay.
Now there has to be some way to ascertain them, and these are very difficult group of patients because we all have undergone the same thing. So one important thing is, which can be helpful, is to get a field done. In these cases, you get field done 5 times. Every time field loss would be different, because he is telling a lie to obtain a wrong field. He wants to get a field done which have a field defect, but obviously he cannot replicate that defect a second time. So you get field test done 2 or 3 times, and every time the defect would be different. Then I think you will have a strong suspicion that patient is telling a lie. So that's one parameter. But yes, these patients are very difficult because we know that they are telling lie, but very difficult to ascertain.
Yeah. Thank you.
Yeah. So thank you, Dr. Vishweshwaran. Please collect your certificate.
Dr. Nidhi Gupta, I think Dr. Rajesh Saini and Dr. Nidhi Gupta is not there. So we can have discussions. Any questions from the audience? Dr. Nidhi Gupta? She's talking on wavefront aberrometry and eye trace.
Good afternoon, everyone. My topic is eye trace, a visionary tool in ophthalmology. What is eye trace? What does eye trace do? It is a 6-in-1 system. It does ray tracing aberrometry, corneal topography, autorefraction, pupillometry, keratometry, and tear film analysis. Why do we need eye trace? Customized procedures like custom LASIK and premium IOL surgery are raising patient expectation. Patients want supranormal vision. Patients are 6/6, but they are unhappy. Visual function analysis tools are needed to assess quality of vision like eye trace. The eye trace is needed in screening of patients with premium IOL candidates to diagnose dysfunctional lens syndrome in dissatisfied refractive and multifocal IOL patient for precision in toric IOL implantation and tear film analysis. What is the principle of eye trace? Ray tracing uses laser beam parallel to the line of sight through the pupil. It measures the exact location where the laser beam reaches the retina by means of retroreflected light captured by reference linear sensors X and Y. Sequential series of infrared beams on the order of 100 microns and 785 nanometer wavelength each is projected into the entrance pupil parallel to the eyes. 64 laser beams have been projected through the entrance pupil 4 times each at high speed, and it is processed in data processing unit. What data do we get from eye trace? Retinal spot diagram. It reveals the patient's refractive error, aberration, and data of point spread function. And modulation transfer function. Simulated vision. It clinically determines visual discomfort that is reported by patient. It allows examiner to see what patient sees. Corneal and internal aberration. Root mean square gives a quantitative measurement of ocular aberrations measured in microns. RMS is obtained for total ocular aberration as well as for each component of ocular aberrations. Blur and double vision symptoms are caused by coma aberrations, glare and halo by spherical aberrations, and starburst and comet tails by trefoil aberrations. Here's the Chang analysis. It consolidates high-order aberration data from all sources on one screen. This is the prime dashboard of eye trace. It gives us all critical information accessible on one screen. CPI, it is corneal performance index. DLI for dysfunctional lens index. If it is less than 5, the cataract is actionable. QVI for quality vision index. There is a button called toric toggle which simulates post-op vision with or without spheral cylindrical correction, which can be used for patient education. What is dysfunctional lens index? It measures quality of vision in aging lens. Lower DLI means reduced visual function. Here E-optotype shows quality of vision from internal optics. There are few cases where eye trace can be very helpful. 21-year-old male patient presented to us with complaint of diminution of vision in left eye. On examination, right eye was 6/9 with pinhole and left eye was 6/18. Keratometry was done. It was 2 diopter astigmatism in both eye. On dilatation, AR reading was very variable. In slit lamp, we find out right eye was within normal limit and left eye had lens coloboma. Fundus was within normal limit. We did aberrometry. We can see from the prime dashboard here that cornea is good. DLI is 2.1 and overall visual quality is 0.8. Here Chang analysis shows higher order aberrations are mostly internal, that is of trefoil type. He is the prime candidate for the clear lens extraction for refractive surgery. In eye trace, we also can check the rotation of the IOL by toric check function. Here axis where the lens is positioned, where the corneal cylindrical axis, power of corneal cylindrical versus power of internal cylinder, what is the current refraction of the patient, and what can we predict post-rotation refraction. Here's a case 2, where a 70-year-old male patient presented to us with a complaint of poor quality of vision in right eye. On examination, best corrected vision was 6/12. On slit lamp examination, patient was pseudophakic with one haptic in sulcus and another one in back. Fundus examination was normal. So aberrometry was done to find out the cause of the poor quality of vision. Here we can see in prime dashboard the DLI is 3 and it is poor quality vision due to overall tilt of the IOL. Chang analysis shows mostly higher order aberration, mostly from internal side. Visual function analysis corresponds with the complaint of patient due to the IOL tilt causing blur vision, mixed focus, and significant starburst. So we, on the basis of slit lamp examination eye trace finding, we advise patient for IOL rotation in the bag or IOL exchange. Here is a case 3, where 25-year-old female patient presented to us with complaint diminution of vision in left eye. She was operated for ICL in 2021. Her left eye vision was 6/18. We did the toric check from this from eye trace, and we can see here the ICL has been rotated. So we can plan a rotation on the basis of this software. We can see here post rotation the vision was perfect. Another one function can be done on eye trace is TFL analysis. It records 6 to 12 second video sequence of placido ring reflection on the tear film. The powerful algorithm quantifies tear film quality by analyzing sequence for contrast, shape, and continuity. It can measure T-bar, visualize lipid waves, and track placido ring changes. Thank you.
Nice talk. Do we have any question for her? So basically it's a new tool, and sometimes it gives very useful information when we are at loss that why patient is having so many subjective symptoms. But I think only caveat is that sometimes you are too much guided by eye tracing, and again it does not have a strong correlation with the subjective symptom. So patient may be living with those kind of abrasion throughout his or her life and not worried for them, but eye trace may come out with a glaring map that patient is having too much of abrasion and one should treat them. So this is the only caveat, otherwise it's a very good and informative tool. Thank you. Please collect your certificate from Dr. Vatsalya. So this brings us to the end of our session. We have had very good discussion, very good talks were there, and I along with Dr. Vikas, Dr. Malpani and Dr. Vatsalya thank you all for such a wonderful discussion and talks. And at 1 o'clock we shall be having oration in Hall A. So we all are supposed to be there at 1 o'clock. Thank you. Thank you for your patience here. Yeah. All speakers who are here, we can have a group photograph in front.